time, the results are gratifying. Fibroids, as we all know, are capable of making a patient's life miserable due to menorrhagia causing severe anemia, dysmenorrhea, increased frequency of micturition, and to the extent affecting a quality of woman's life. Such a benign nature of masses, but ability to create a havoc. So let's learn about the basics and nuances of these two very important gynecological issues from our expert faculty. I'm sure today will be a day of academic enrichment for every one of us. Over to you, Supriya.
Thank you. Without delay, we are moving towards our first session. I request Dr. Sharmila Guram Madam and Dr. Bharti Tadwalkar Madam to chair this session. Dr. Sharmila Guram Madam, she is a senior consultant at Ankur Nursing Home. She is a past SOGS president. She got a Best Society Award. She had special interest in NDVH and high-risk obstetric management. Dr. Bharti Tadwalkar Madam, she is a senior consultant, obstetrician and gynecologist. Thank you. Over to you, ma'am.
Good morning, all. We are going to start with the first session of this academic feast. As we all know, in our regular OPDs, we come across with many cases of fibroids at different age groups with different types of fibroids from a small to a large, with much confusion about management. Sometimes we get confused. And I think today we are going to get some relief of this from this confusion, as today's topic is everything about fibroid that we must know, and it is by there is slight change. This topic is hysteroscopic myomectomy, safe limits. And this is by Dr. Aditya Khurd. He is consultant gynec endoscopic surgeon and IVF specialist at Khurd Hospital. He has done fellowship in minimal access surgery and fellowship in reproductive medicine. He won the best paper prize at 12 AAG RCOG and national conferences, and presented papers at international and national conferences. I request Dr. Aditya.
Good morning, everyone. Thank you, Dr. Bharti Madam, Dr. Guram Madam, for the kind introduction. At the outset, special thanks to the Solapur Obstetric Gynec Society for inviting me and being a part of your CME. So as Madam and everyone rightly said, fibroids and PCOS is our day-to-day issue, and we need to update ourselves with current knowledge for handling these common problems. I will be speaking on a specific topic, that is hysteroscopic myomectomy. Greetings to you from Pune and the Pune Obstetric Gynec Society. In the next few minutes, we'll be discussing about the classification system for fibroids, preoperative preparations, and through case scenarios, discuss about the instrumentation, techniques, and distension media used for hysteroscopic myomectomy, along with evidence and how to ensure performing a safe hysteroscopic myomectomy. Though this is one of the commonly done procedures, many a times you all must have experienced safety can be a concern. And so we will highlight this during the next few minutes. So whenever we plan hysteroscopic myomectomy, there are certain considerations that we have to look at before proceeding for or posting a patient for surgery. Very importantly, a detailed history will help us know her age, means considering her age and whether heavy menstrual bleeding is the concern or it's infertility or it's both. Severity of symptoms also plays an important role, whether surgical management is essential or can be managed medically. Desire for future fertility is also important. And once his clinical part is over, mapping the fibroid is very important to know the location and to determine the route of surgery. We have two-dimensional ultrasound to help us locate, but now with the advent of three-dimensional, we get better idea of the location and also to decide the route for the surgery. Initial years we were using MRI, but now with good three-dimensional transvaginal probes, 3D mapping is much easier and easy and in our OPD. There was this EHG classification which is commonly used, where it classifies submucous myomas into 3 types. Type 0, where the fibroid is entirely in the endometrial cavity. Type 1, where less than 50% myometrial extension. And type 2, when more than 50% myometrial extension is there. In 2011, the FIGO also came with another classification where it classified all types of fibroid, whether subserous, intramural, or submucous. When it comes to hysteroscopic myomectomy, we are basically dealing with type 0, 1, and 2. So whenever it is about hysteroscopic myomectomy, certain safety considerations have to be taken into account, especially what's the size of this fibroid, whether it is 3 or below, or whether it is beyond that, around 4 or 5 centimeters. The number, are we dealing with a single myoma or multiple myomas in the intrauterine cavity? And location, especially for type 2 myomas, though we know type 2 means more than 50%, that again is a spectrum, whether it is just above 50% or a major chunk is in the intramyometrial portion, because that is going to decide your route, whether you're going to do it hysteroscopically or you're going to have a lap guidance, or you would straight away prefer doing a laparoscopy for ensuring patient safety. And of course, instrumentation and expertise is very important. A good preoperative preparation is as important as the surgery itself. Optimizing patient for surgery, may it be hemoglobin, may it be her sugars, her blood pressure. Counseling your couple and her patient and her relatives also helps you have a smooth surgery and a smooth post-operative outcome. That time you need to discuss about the route that you have planned based on the clinical scenario and the mapping that you have done for the patient. Whether you are going to do this as a first one-stage procedure or informing them in advance that this is a big fibroid, it may require a second sitting. This will help for the relatives and the patient to make a good decision and a proper understanding later on. And of course, instrumentation and distension media all have to be ready before you go. There can't be intraoperative changes and suddenly you are searching for a different instrumentation or a media. Let's come to our first case. So this was a 33 years lady. She presented with heavy menstrual flow for a prolonged period, not responding to medical management. Ultrasound was showing a 5 centimeter anterior wall submucosal myoma. There was intramural myomas as well. We did a fibroid mapping for this patient. And here you can very clearly see that this is a myoma which is occupying the entire endometrial cavity. And of course, there are few smaller sizes intramural myomas. So in view of her symptoms, patient was wanting a minimal access surgery. So we discussed with her and a hysteroscopy was planned. So whenever it comes to an operative procedure, always in addition to your 3D ultrasound, a diagnostic hysteroscopy always useful before you go for the operative part. Please remember, it is in the same sitting, not that we have done hysteroscopy and we are planning operative later on. In the same sitting, good to put in a scope, diagnostic sheath. So here you can see it's a large intracavitary myoma with the broad base arising from the right cornu to anterior wall. So here you can see the brace. You can visualize the ostia. This is the right ostium. So we have confirmed our diagnosis as type 0 submucous myoma. Following that, we took our operative hysteroscope. Bipolar resectoscopes are preferable. Initially, we were doing all these cases using monopolar energy, but now with bipolar energy, you can use normal saline. Your chances for electrolyte imbalance due to glycine are much lesser. Normal saline at the most may cause fluid overload, but you are keeping a watch over the fluid deficit. So using a bipolar resectoscope, loop electrode, we take deep bites into the surface. Important point that we have to remember is never dislodge the base of the myoma initially. The moment you dislodge the base, the fibroid is going to keep moving in the cavity and you will never be able to move it. So you start from the periphery and reach the base at the end. Now, as this is a big myoma and you're taking big chunks, the chunks are going to obstruct your view at some part of your procedure. And then removing the remaining portion may be a little difficult. So in such cases, what you do is you have to be quick, but you stop in between. You remove these chunks with the help of a curette or an OM forceps and improve the clarity, the view that operative feel, and then again proceed with the bipolar resectoscopy. So here, as the chunks were increased, means completely occluding our view, we have removed them, and following that, we have again completed the procedure using the bipolar resectoscopy. So a curette or an OM forceps is very helpful for clearing the chunks. Visualization is much better after that because major part has come out, and then the remaining ones you can do it. You must ensure that you complete the myomectomy, but don't go further deep in. So whenever you see pink, red, bleeding tissue, you know you have reached the myomectomy, and that is where you need to stop, because our intention is only a myomectomy and nothing more. If you go further deeper in, then you are risking chances for perforation or excessive bleeding, and also you are increasing chances for intrauterine adhesions, especially if the lady is having a desire for future fertility. So here you can see the ostia are well visualized, the fibroid is completely out, and this is the post-operative picture. So coming to resectoscopes, as I discussed, monopolar resectoscope requires non-electrolyte medium, but now with bipolar resectoscopes, you can use normal saline. Fluid overload is the only concern. With glycine, which was used with monopolar, electrolyte imbalances, cerebral edema were always an issue. And also you avoid chances for thermal burns. Though bipolar resectoscopes are costly, they are very commonly available and help you ensure or give you a safer outcome. Monopolar, not that it's not used, but you have to be very quick so that you avoid the complications. Fluid management, as I discussed, is very important for prevention of excess absorption. Early recognition is very important, and choosing the distension medium least likely to cause complication, which is normal saline over glycine, is necessary. Fluid measurement, we commonly use the manual method. It is subject to error. Of course, if we have certain finances available, you can go for the electronic measurements with the new power distension pushing media machines that are available. They give you an electronic idea of the fluid deficit. Simple to remember, always keep lower cutoffs for fluid deficits. When it is glycine, ensure you don't cross more than 1000 ml fluid deficits. When it is normal saline, fluid deficit 1500 and beyond, you should raise an alarm and prefer not to go beyond that. Coming to our second case, this was a 12 years primary infertility. When we did an ultrasound, 2 centimeter echogenic lesion was seen near the fundal endometrium. So to confirm and to further treat, we decided for hysteroscopy. As discussed, we first do a diagnostic hysteroscopy. So initially, if you see, the cavity looks apparently normal, nothing abnormal. So careful visualization is very important, because at times these small lesions may not be seen easily. So here we are. What we can see a bump on the anterior uterine wall. So very careful observation, though it is a 2 or 3 minute hysteroscopy, is essential. Don't hurry to take out the scope. You might miss these small myomas. The bigger ones will never be missed, but the smaller ones may be missed. So what we saw was, this is an endometrium covering a myoma. and which is distorting. So what this was a type 1 submucous myoma. Now, whenever we have smaller myomas, especially in infertile patients, a scissor can also help you resect that myoma. So what we planned was by cold scissors, we shaved off the endometrium which was covering the myoma, and now you can see a glistening white tissue very prominently seen, further confirming our diagnosis that this was a submucous type 1 myoma. So there is something called as cold loop myomectomy, where you dislodge the base of the myoma by just giving blunt traction and then use your sharp scissors to enucleate it from its base. As it is a small one, we are going towards the base and then trying to resect it from the underlying myometrium. So for small myomas, a scissor was sufficient. Complete myoma was dislodged from the base. Few bites just to complete the surgery. The slide is gone. Okay. Yeah. And this is the post-operative picture where we were able to do it using cold scissors. So hysteroscopy has evolved over a period of time. Initially, we were using 4mm hysteroscope. And whenever it came to operative hysteroscopy, then again, we had to dilate the cervix because the diameter of operative hysteroscopes with a 4mm hysteroscope further is much bigger. But now we have modern day 2.9mm hysteroscopes and now also 2mm hysteroscopes, wherein the complete diameter with the operating sheath is going to almost 3 or 4mm. Cervical dilatation may not be required. And as these hysteroscopes also have an operative channel, you can pass in scissors, you can pass in graspers, and you can complete the surgery in an OPD basis or on a daycare basis without needing any cervical dilatation pre-operatively or intraoperatively. So hysteroscopy has evolved, smaller diameters, inflow-outflow system is better for better visualization, operative channel is facilitating your operative procedures, and a daycare procedure for the patient. So looking at this study, which looked at hysteroscopic myomectomy for submucous myomas, what it found out was the surgical time was very limited, complications were minimum, and many of these patients have good outcomes clinically post-procedure. That coming to cold loop myomectomy, which I discussed during the previous surgery, that the concept is whenever you're encountering a large myoma, in our case, it was a smaller one, what is preferred is that you resect the superficial part of the myoma, which is in the cavity. The one which is intramyometrial, don't hurry to resect it because thermal energy will damage the endometrium. So what you do is you just mechanically enucleate the intramyometrial part, you push it so that it comes into the cavity, and then you proceed with your submucous resection. So the advantage is safe and more effective compared to complete resection, prevents electrical or thermal damage to the myometrium, and further chances for intrauterine adhesions. So even with type 2 myomas, hysteroscopic myomectomy is possible. At times, even a single step procedure is possible. So this study, which looked at effectivity of single or double step surgery, what it found out was whenever it was type 1 myomas, almost 88% they could successfully remove in single sitting. And whenever it is type 2, the chance was 80% to 82%. So counseling your patients about this is very important in their simple language so that they are mentally prepared after the surgery. Yes, that this was a big myoma. Everything may not be possible in the same sitting, and unnecessarily risking her for complications is not the right way. So friends, safe limits have to be drawn in hysteroscopic myomectomy, and safety has to be ensured at every step, right from pre-operative patient selection, patient profile optimization, good preoperative preparation, good instrumentation, surgical technique, fluid management. The skill and the experience of the surgeon matters a lot, lesser time for surgery, lesser the chances for complications. The moment you increase the time, the fluid is going to go more, because the moment you resect the myomas, the blood vessels open up, and that is when the high pressure it goes into the circulating system, increasing complications for the patient. And a good post-operative management also is very important. Submucous myomectomy, there can't be safe limits fixed for every patient. Every case is different, so an individualized approach is important. You may have a limit depending on the patient's age and profile for a certain patient, but you may extend your limit for the other patient, but ensuring that you have taken safety at each and every step. So we need to stay in our limits, because we all know there is a hidden danger beyond that limit, and it may be perforation, it may be bleeding, fluid overload related issues, electrolyte disturbances, and rarely pulmonary complications and increased morbidity and mortality. So though hysteroscopic myomectomy apparently looks like a straightforward procedure, we all have experienced at times difficult, challenging situations. If we take proper precautions, we are going to increase safety for our patients, which is prima facie important. Coming to my last case, this was a 32 years primary infertility case. USG, when we did, we saw that there were multiple submucous and intramural myomas. So this is a hysteroscopic picture. What you can see, the entire cavity is studded with myomas. Some are large, some are small. So what do we do? Take our bipolar resectoscope and start resecting it? Absolutely no. If we resect this cavity, we are going to cause Asherman's for her. If you see, this entire cavity is studded with myomas. If you are going to damage all walls of the uterine endometrium, you will leave no normal endometrium for this case. So this is a time where you should take the right decision and prefer a laparoscopic approach. In this case also, we preferred a laparoscopic approach in view of multiple myomas all over. Laparoscopic approach is much safer. You are able to visualize the myoma specifically, and with specific visualization, you can easily remove these myomas without damaging the normal endometrium which is surrounding that myoma. Please remember, whenever you do thermal loop myomectomy hysteroscopically, some part of the surrounding endometrium does get damaged. But with this, even if you have to open the endometrial cavity, it's not wrong. Rather, open the cavity, visualize the myoma specifically, and then remove it. That is much safer rather than thermally damaging the normal endometrium. And then, of course, laparoscopic suturing gives a good approximation, ultimately ensuring patient safety and giving a good outcome to these patients. So hysteroscopic myomectomy is surgery of choice for cavity distorting myomas. Larger myomas, we do prefer resectoscopes. Very small myomas, you may consider using scissors. Prevention is better than cure. Bipolar resectoscope has improved safety. Normal saline avoids electrolyte imbalances. We should operate under optimum intrauterine pressures so as to have adequate visualizations, but at the same time avoid complications due to fluid overload. We have to be quick. Operative time is very crucial for the safety. Strict fluid deficit and vital monitoring. Use of diuretics if required post-operatively. And if deficit is more, please don't hesitate to stop. Sometimes our ego, our pre-decided thoughts want us to push beyond, but you are risking danger as we discussed prior. We need to stop. Involve your team, talk to the relatives, and many a times they will understand that if you have ensured safety for the patient, they won't hesitate to go for a second procedure later. Prevention and early recognition of complications is going to ensure safety. Every case is different. You can't have a you can't have a fixed approach for every patient. Decision for route of surgery should be taken judiciously. And even if it is lab, don't hesitate to go for lab. There is nothing wrong in doing that. Whenever hysteroscopy, prefer that. Whenever it is a combined approach, do go for it. So two very beautiful mornings. One yesterday when I came after a long time to Solapur aboard our Indian Rail, and another very beautiful morning today with all of you. So thank you very much for patient hearing.
Thanks, Dr. Aditya, for nicely explaining all safety measures about this hysteroscopic management of fibroid. And one more thing, I just because Sanjeev Ghosh sir is very well known. He is like a family member to our SOGS, and it's a very nice experience that you are here for the lecture.
Thank you, madam.
Thank you, sir. I request our chairperson to please felicitate Dr. Aditya Khurd, sir.
Questions? We'll take any questions, question answers immediately.
Madam, patient was not willing for a abdominal approach. And if you see the size of those fibroids were smaller.
But did she was symptomatic later?
Fortunately, she didn't develop any symptoms afterwards. As we all see, we have tackled so many small fibroids during cesareans or at times incidental finding. So the submucous one was causing her heavy menstrual bleeding. She wanted a minimal invasive approach. So patient consideration is very important, and submucous myomectomy reduced her flow. She was asymptomatic. She did not require any surgery for that intramural part.
So before.
Yes.
that
So the fiber.
That she may continue to have symptoms because of that.
Her counseling was done much before, and the mapping helped us to discuss with her. So the mapping helped us discuss that the major part is the submucous one. There are small ones. She may require a repeat surgery for her remaining ones. But as she planned that she wanted only hysteroscopy initially, we did that and she got relief. So she didn't have to tackle the remaining ones.
Thank you.
Okay.
Did you in time plan second look hysteroscopy for these hysteroscopic myomectomies?
Sir, if there are multiple myomas which we have done, if the myomectomy has been done for multiple myomas, especially where we have opened the opened the cavity laparoscopically, or if there were myomas significantly, only then we have done a re-look hysteroscopy. If you see the literature, they do recommend that if it is an extensive surgery, multiple myomas, you should do a repeat hysteroscopy after 3 months or so. The reason is sometimes you may have some intrauterine adhesions, so which you can tackle them. What we do is that we do a good endometrial scanning after that. And if you see a good triple line endometrium, your chances for intrauterine adhesions are very minimal. If the endometrium remains thin, or you see certain echogenic lesion inside the cavity, your ultrasound also gives you a better visualization. 3D is now there, which we very routinely use for our patient. You can get a guidance whether you need to do a relook hysteroscopy or whether you can go ahead with your infertility treatment.
Any idea of giving depot preparations before you undertake hysteroscopy?
Okay. So very, very relevant question, especially type 2 myomas, where you are tackling a 3 centimeter, 4 centimeter myoma. You know the surgery may take time. Giving depot preparations pre-operatively has been known to reduce the size of the myoma. The surgery becomes much easier and easy to do a myomectomy hysteroscopically itself. Another method that is being that we use is injection vasopressin injected intracervically also has been known to reduce the intraoperative bleeding. See, ultimately, when your bleeding starts, your visualization becomes difficult. You can't complete the procedure. But if you have good preoperative methods, either depot preparations where the myoma is small, procedure time is less, or you inject dilute vasopressin, the blood loss is less, you can complete the procedure quickly. So that can be used.
I appreciate you talking about maintaining low pressures during hysteroscopy.
Yes, very important.
But I heard Osama in one of the conferences, because they would raise the pressure to very high limits so as to have better visualization and reduce the bleeding in the intra.
So I was fortunate to attend few of the international hysteroscopy conferences. There is two schools of thought. There is a group of surgeons who prefer optimum pressure. And as sir discussed, there is a school of thought where they use very high pressure. See, ultimately, we are all practitioners responsible for our small nursing homes. All of us may not have a institute cover every time we do a case. I think safety is more important rather than going very aggressively with high pressures. When we all know that if we use low pressures or optimum pressures, our safety is much better. Maybe out of 10 cases, 1 or 2 may require a second sitting. But the complications of very high pressures, especially with operative hysteroscopy, when the vessels channels open up and suddenly the fluid goes, that may not be justified. So I am of that school of thought that maintaining normal pressures, optimum ones, so that good visualization, but at the same time, quick surgery is also very helpful. So I usually avoid very high pressures because you are risking the patient there.
I appreciate your school of thought of Sanjeev Kurd
Hmm.
because the patient safety and the systematic way in tackling the appreciate it. Thank you very much.
Because we are not an hero doing anything only by one sitting or only by one route. So many times we counsel patients and use both routes, and there is nothing wrong in that. But patient is ultimately satisfied that you gave them a safe outcome.
Plastic tumor in the neck. Basic etiology is idiopathic, familial, growth factors, and hormones. So etiology, the clear etiology, precise causes is not known, but few genetic considerations are there. About 40% have chromosomal abnormalities in different forms like translocations, deletions, trisomies, and all. More than 100 genes were found in down regulating the fibroid cells. Then the hormones, estrogen and progesterone appear to promote so basically estrogen and progesterone appear to promote the fibroid cell growth. Estrogen, progesterone is the culprit for the fibroid, the myomol, the myometrial cells to grow. Because what estrogen will do, estrogen will it will enhance the receptors for the progesterone, and ultimately, even though estrogen is raised, the action, final action will be of progesterone because it will express and increase the progesterone receptors. So progesterone is the main culprit behind the myoma growth as far as the hormonal effect is concerned. That's why all the medical managements, they are moving around progesterone only, like progestins, antiprogesterones, and all. Here, the incidences of myomas are higher in estrogen replacement therapies. The decreased incidences are found in athletes, low body mass, or increased parity where estrogen is a bit deficit. Estrogen induces increased expression of the progesterone receptors, thus promoting the oncogenic effect of progesterone, which is the culprit for the myoma growth. Then growth factors, there are different growth factors which can cause proliferation of these cells. The different growth factors like tumor growth factors, vascular endothelial growth factors, insulin-like growth factors, and all. Then few risk factors. Age. The risk age is increased risk during childbearing age group. Body weight. Even 21% of the myoma chances are increased if the weight gain is around 10 kg more than. Then black women, they develop fibroids 2.9% more than the white. Diet rich in meat, beef increases the risk of myomas, while diet with green leafy vegetables reduces the risk. Then family history, first degree relatives 3.5 times more risk of developing fibroids. Then the endogenous hormonal factors like early menarche, late menopause, hyperestrogenic statuses, then increased expression of the responsiveness of the progesterone receptors may cause increased risk. Exercise. So the women who doing regular exercises are at low risk than those do not do the exercise. So OC pills doesn't play a definitive role as the same with the estrogen replacement therapies. This is the risky thing for all other diseases, but for fibroids, it reduces the chances of myoma by decreasing the estrogen levels, conversion of androgen to estrone, or hydroxylation of estradiol, or increased levels of serum sex hormone binding globulins, and the sex hormones are lesser available in the circulation. The pregnancy, pre-existing fibroids may undergo some degenerative changes. Increased parity associated with lower incidence of the fibroids. Tissue injuries may produce growth factors, can be a culprit for the myoma growth. So onset of menstruation at an early age, diet, low levels of vitamin D, drinking alcohol, obesity, nulliparity are the few risk factors. Then different types and classification of the myomas. Those are the fibroid which occurs to the body of the uterus, then intramural, then submucosal, subserosal, pedunculated, broad ligament myomas, cervical myomas. Those are the different types of the myomas. In clinical presentation, basically, most of the myomas are asymptomatic. Then abnormal uterine bleeding, mostly associated with the submucous myomas or myomas, those are destroying the endometrial lining. Then infertility. Then pain, swelling, and pressure effects in cases of larger masses. So abnormal uterine bleeding in the form of menorrhagia or metromenorrhagia in cases of infected fibroid polyps or submucous polypoid lesions. And during younger age, we are seeing the myomas, even though larger myomas are also, we used to see in younger age, may suffer from heavy bleeding, pelvic pain, bloating, or frequent urination, constipation, and sometimes they overthink and they land into depressive disorders. So diagnosis, basic diagnosis is history and our clinical examinations. So in general examinations, if fibroids are larger, then one can feel as a firm nodular mobile mass arising from the pelvis. Then on per speculum examination, if mass is larger, cervix is pulled up. Per vaginal examination, the enlarged uterine mass, nodular mass without notch and transported movements are present on clinical examinations. Then other imaging investigations, those are 2D, which gives very much sensitivity for myoma diagnosis. Then sonohysterography gives an idea regarding the submucous myomas. Then the 3D ultrasound, this is the fundal fibroid. This is the fibroid and this is the endometrium, which is indented by the myomas. So it gives a precise diagnosis. MRI is the best investigation, imaging investigations as far as the myoma is concerned. MRI mapping nowadays is used to be done preoperatively just to how to approach the myomas, where to take the incisions, how many myomas we have to take out. So it will give us a gross idea for the surgeon also. Then imaging investigations include laparoscopy and hysteroscopy, which gives the 100% accurate diagnosis. Then few complications, general complications like anemia, menorrhagia, abdominal pain, urinary tract infections, twisted fibroids, fertility related like infertility, miscarriage, premature births, labor pains, these labor problems and PPH. Then infertility due to myomas is basically alteration in the local anatomy and endometrial function. Functional changes including increase in the uterine contractility and impairment of the endometrial and myometrial blood flow. by the fibroid itself can reduce the implantation, and this is it can lead to infertility. So before treatment, we have to classify the myomas. Basically, the myomas are classified as a subserous, submucosal, intramural, and pedunculated myomas. And the submucous myomas again classified into different three types. First, 0, the endometrial cavity. Then type 1, less than 50% myometrial extension, and type 2, more than 50% myometrial extension. Then the FIGO classification system is basically evolved to explain the myoma uniformly, or there has to be uniformity between the different consultants to explain a particular myoma. They have developed a good system. So here they again classified as 0, 1, 2 for submucosal myoma, where 0 is inside the cavity. Type 1 here it's less than 50% intramural. Type 2 more than 50% intramural. Then type 3 it touches the endometrium but it is the intramural. Fourth intramural. Fifth subserosal with more than 50% intramural extension. Then fifth subserosal but less than 50% intramural. Seventh subserosal. Eight other, and it has classified the hybrid leiomyomas. That is, it includes 2 to 5 types. That means appears subserosally as well as submucosally also. Then this classification is depending upon the histology or the life cycle of the fibroid, not much useful. Then management. Diagnosis is important prior to decide the management and management options. So every fibroid does not require treatment. Most of the times people used to think that don't go to the laparoscopic surgeon, he will operate, because people used to think that the scope is like hammer. Whenever they used to say they'll put the scope and take it out. So each and every myoma doesn't require treatment or removal. So the management, I have divided it in different things like details regarding the patient, regarding the myoma and the available options. So details regarding the patient, age, marriage, parity, then asymptomatic or symptomatic myomas, and does it affecting the fertility. Then details regarding the myoma, those are its location, uterine, cervical, subendometrial, that is different type of the fibroid, size, number, and complications. Then what are the management options available? Those are, first is the expectant, then medical, then surgical, and other modalities of treatment. So expectant management in cases of small myomas, asymptomatic myomas, or those who are willing for close follow-up, one can go for expectant management. Then what are the management options? Those are the medical management. Basically, what are the aims behind the medical management is to relieve the symptoms, reduction in the tumor size, those who are unfit for the surgery, not willing for surgery, preoperatively and prior to menopause, as well as medical therapies indicated in post-operative cases also as an adjunct therapy. Then the drugs used for the symptomatic cases, iron, NSAIDs, and supportive therapies. Specific drugs, those are GnRH agonists, GnRH antagonists, then antiprogestins, synthetic steroids like danazol, selective estrogen receptor modulator, selective progesterone receptor modulators, combined nocipils, LNG, aromatase inhibitor. So all these drugs, they used to play around the progesterone only, what I told initially, because progesterone is the main hormone culprit and the other drugs. So GnRH agonists, these drugs, agonists which will produce a hypogonadotropic hypogonadal conditions like pseudomenopause and reduce the estrogen and progesterones. Similar way, the GnRH antagonists also, they block the pituitary GnRH receptors and subsequent reduction in the estradiol level. Combined ocipils, definitely they used to improve the menstrual bleeding, but for the uterine size and the myoma size and volume, it plays a doubtful role. Then again, the aromatase inhibitors like letrozole and anastrozole, their role is also not so clear. Then selective estrogen receptor modulators like tamoxifen, but for these drugs, the side effects overweight the benefits, so not much tried. And the progestins, those are the depot preparations can be tried. Then selective progesterone receptor modulators, those are mifepristone and ulipristal, most commonly used drugs for the myoma with good effect on the volume of the uterus as well as the myoma. So ulipristal acetate, which reduces the size of the myomas by blocking the effects of the progesterone, it will reduce the volume. 5 milligram and 10 milligram oral preparations are available. Then the antiprogestins like mifepristone, 10 milligram and 25 milligram preparations are available. And basically all those preparations, they plays around the progesterone because it is believed to be a physiological regulator of the uterine fibroid growth. So it is as the NRHN allows lesser side effect, oral route, good tolerance. Treatment of mifepristone milligram daily for 3 months significantly reduces the bleeding or symptoms, then uterine as well as the myoma volume. So these are the pros and cons regarding the different preparations. Still, the mifepristone and ulipristal, they have a good tolerance and can be used for the medical management of the myomas. Those are effective with reduced recurrence rate, tolerability, and comparable with the GnRH agonists. Then the surgical management, the management conservative and radical management. So surgical conservative management is nothing but myomectomy. So for myomectomies, the basic key points, proper exposure has to be there. Like in open surgeries, usually nowadays, the myomectomies, what I'm going to show is being a laparoscopic surgeon, I used to operate only laparoscopy at our center. So I'll show you the laparoscopic approaches only. But even though for open surgeries, the same thing, proper exposure has to be there. Then adequate incisions. There should not be a CPDs, make a CPDs and struggle to deliver the myoma, to enucleate the myoma. It should not happen. Then correct planes is the key. Then bloodless dissection, proper obliteration of the dead space and approximations, safe modulation, without which the myomectomy is incomplete, close follow-up and combined medical treatment if required. The myomectomy, the key points. Here, the vasopressin is injected, you can see the effect. Then very simple gadgets are used, that is monopolar hook. You can see the bloodless dissection, then clear planes. I'm repositing the whatever the myometrial portion back with the myometrium, and only the naked myoma is enucleated. This is how we can do the myomectomy. Because we used to have a time bound for presentations, I have selected a few cases where we will have different varieties of myomas in single cases, like for this case, fundal, posterior, and anterior wall myomas. So instead of playing different 3 videos, one video will explain all these things. So this is the large posterior wall myoma. This is the fundal one, right side, left side. This is the right side fundal, another, and anterior lower segment myoma. Again, vasopressin is given. You can see the effect. Then good exposure means you have to expose the myoma. Here you can see the POD, lateral pelvic walls, anterior abdominal wall. So this is what the exposure we expect in laparoscopy. So if you dissect it clean, you won't miss the planes if you do the bloodless dissection. and that will make life easier. So this is what the clean dissection is, and myoma is enucleating. You can see the naked myoma. There is nothing over the myoma, and the proper gadgets at their places is luxury. So you can reposit whatever the things are belongs to the myometrium. You reposit it back and enucleate the myoma. You can see this is the myoma bed, myoma which is coming out very nicely. Even it is vascular myoma, you can see the vessels over the myoma. This is the myoma bed which is a clean. And now next our duty is to obliterate this myoma bed and suture it properly. This is the posterior wall. Then the fundal myoma, again, the same rule, minimum incisions, maximum myomas. So with one incision, I'm approaching the two fundal myomas. So this is one, and this is the second fundal myoma. Again, with very simple gadgets, I'm doing it bloodless dissection. Then myoma has to come out properly. It has come out, this is the myoma bed. Then the second one, again, same thing. Whatever the things push towards the myometrium, only enucleate the myoma. So this is the third myoma has come out from the fundal region. Then anterior lower segment myoma. After myomas are taken out, the next and foremost important thing is to suture it properly. So this is the myoma bed. You can see as such there is no bleeding. When we suture or obliterate the myoma bed, I think there should not be a need to approximate the serosal surface. It has to be like that. Like how we used to take the subcuticular sutures, then no need to take the skin. It has to be like that only. See the obliteration. So proper obliteration of the myoma bed is very important. And that the suture should not be too tight, too loose. You can say the obliteration of the myoma bed. And then these are the posterior fibroid myoma bed. Then one can suture the myometrium and serosal surfaces nicely, so that this is the best trick to avoid the or invitation to the future adhesions. So if we suture it well, it will prevent the adhesion. So instead of going for other barriers, this is the most common thing which we can do. So this is how we have sutured these myoma beds. Then the deep bites here. Again, this is the vicryl, not much of the fancy things. So this is the simple number 1 vicryl I am using. So suturing skill is must while tackling the myomas. So this is the vicryl. One can use the needle length as a vicryl length also if it is short. Then myomectomy is incomplete without morcellation. So this is the morcep endobag where all 1, 2, 3, 4 myomas are put and safely morcellated. So this is how the myomectomy we can perform. Then myomectomy for large posterior lower segment myomas. So this is an unmarried girl, just while talking the risk factors for the age and management. Even the unmarried girls are having almost, she was at 29 when I operate. So this is the vasopressin. I am taking elliptical incision at the sacral promontory level. And that big was the myoma in such angle. So myomectomy for submucous myoma. Here again, I'll show you one case where in the same case, the intramural with subserosal extension and submucous myoma. So that two cases will be covered in one. So this is effect of vasopressin. This is the myoma here with intramural extension. Here little bit oozing you can see. Why? Because I did hysteroscopy for her initially, that's why. Then this is the myoma which tackled laparoscopically. Here is the bulge you can see, and this is the submucous myoma. So here again, exposure is good. What you require is a good exposure. And here you can see the myoma bed in submucous myoma also. I'm pushing it. This is the myoma bed. And the complete myoma is tackled. You, sir, asked regarding the distension and all. So good exposure rather than looking towards the monitor and pressures and guiding the pressures, increasing the pressure, reducing the pressure. Surgeon has a knob in his hand on which he can adjust the pressure and can have a good look. Unless and until you visualize it properly, you can't operate properly. So for proper surgery, the exposure has to be must. Then myomectomy for submucous myoma associated with fibroid polyp. This is the case where she presented with metromenorrhagia, irregular bleeding. This is the infected polypoid fibroid. This is the myoma and one infected fibroid polyp. So uterine artery ligation. So in cases of large myomas, vascular myomas, large lateral wall myomas, preferably in the lower segment, then combined intramural and submucous myomas, sometimes it is useful, but not mandatory. So this is the case where I'm taking the uterine artery at its origin. So you can see this is the exposure for the uterine artery. So this is the uterine artery, obliterated umbilicus, and this is the internal iliac. So this is how we can approach the internal iliac and the uterine with a very easy method, easy techniques, if you follow it repeatedly. And this is the case for which I had done it. This is the damn posterior cervical fibroid, a big fibroid, where the exposure is difficult. And if bleeding starts, it is very difficult to control in these cases. So the vascular myoma, we will see. This is the vascular myoma. Here, preferably, I have used harmonic because initially I showed the cases with simplicity, monopolar and bipolar. Still, because this is the preoperative predicted thing. Can you see how it is pouring? And it will pour on the tip of the telescope, it will spoil the vision, and it will bleed torrentially inside. So what is the solution? Solution is be bold, give good cuts, and find a correct plane that will make your surgery easy. Then the uterine artery ligation for large lateral wall, lower segment myomas. Here, both myomas are right side, lower segment. This is with anterior wall extension. If you see here, what the thing is, here, uterine artery is supplying the myoma. Can you see? This is the lateral wall myoma. Here is the uterine artery. Can you see the uterine artery? Here, this is the uterine, which was supplying the myoma. So it is preferred to be ligated there. This is the one case. And this is the another case. I'll make it a little bit forward so that you won't get bored. Why this case I have shown is because if you say the size of the uterine, can you see the size of the uterine artery? This is the uterine artery, not internal iliac or common iliac. This is the uterine artery because it is going through the fibroid and supplying the fibroid, and it is a vascular myoma. So in these cases, some vascular prerequisites we used to complete while tackling the cases. So this is what the vascular myomas are. And then after that, you can tackle it nicely because it has posterior wall extension, lateral wall extension, and anterior wall extension. So we have to cut both the anterior wall, lateral wall, and posterior wall. So almost circumferential incision. That's why it is always easier to approach safely. And this is the myoma. You can see the size of the myoma and how the incision of the uterus is, because according to the extension of the myomas, we have to tackle it. Then degenerated myomas. Here is the calcified myoma. Even myoma screw is not getting fit inside here. And this is the cystic degeneration of the myoma. So you can see the what exact cystic degeneration of the myoma which we used to read in the books. So again, similar incision taken. This is the cyst. You can see the cyst. So all cysts are there inside. This is the cystic degenerated myoma, and this is the calcified degeneration. This is again degenerated myoma. Then cervical myomas. This is the left posterior cervical, this is the right posterior cervical, and damn posterior cervical. So here, these three are big myomas situated on the uterine artery and ureter. Here, this is the ureter on left side, and this is this big myoma. These are the purely cervical myomas. This is the posterior cervical. This is again right paracervical. This right side posterior cervical myomas, two myomas, and over the ureter and uterine artery. Here is again extending downwards. This is then posterior myoma. Then we have seen the cervical myomas, anterior, this posterior, right lateral and left lateral. This is the anterior cervical myoma. In case of previous two cesarean sections, this is the bladder. EV fold is open, bladder is pushed, and myoma is out. So this is the anterior cervical myoma. These cervical myomas are again subclassified as supravaginal or intravaginal cervical myomas. We have seen the supravaginal portion cervical myomas, then intravaginal cervical myomas. This is the anterior lip, this is the posterior intravaginal, and this is central vaginal myoma, which is protruding through the cervical canal. So these are the different varieties of cervical myomas in supravaginal as well as intravaginal portion. Then broad ligament myoma, when to remove. As such, there is no need to tackle the broad ligament myomas, but this is when it is large, gives pressure symptoms, then one can tackle the broad ligament myomas. Actually, this case was diagnosed as a large fundal myoma. But what happened intraperitoneally? I thought that this is fundal, so I took incision over it, and this is the uterus fundus. Now, intraoperatively, I come to notice that this is left-sided broad ligament myoma. So, larger broad ligament myomas are also to be tackled to avoid the kinking of the uterus or to get relief from the pressure effects. Then some unusual myomas. This is the myoma tackled hysteroscopically, and the hysteroscope was put through the abdominal port, laparoscopic port. Because here, you can see the rent here in the POD. Can you see the rent? So intraoperatively, again, I called that sonologist and I asked, he was damn sure, no, myoma is there. So through that rent, I put, this is the hysteroscopy, no myoma inside, no myoma outside, and there was a rent. So I thought, just put the scope inside the rent. So through the 5 mm, one of the 5 mm port, I put the hysteroscope inside, and you can see the right paravaginal myoma. So this is the hysteroscope put under vision of laparoscope abdominally, and this is the myoma which was situated in the right paravaginal space. Then these are the few settling myomas. Then after conservative management, what we have, the next option is radical management of the myoma, and that is nothing but hysterectomy. So here, larger the masses, more the easier surgery. So here, a big myoma is there. Nicely, step-by-step approach for TLH. First is the fallopian tube, broad ligament, ovarian ligament. If you proceed slowly, then it will be a bloodless thing. And because the ligaments are stretched, it is very easy to tackle the larger masses laparoscopically. So here again, bladder, because it is stretched, pulled up by the myoma, it is very easy to dissect and push the bladder. So this is how uterus is devascularized completely along with the myoma without much of the blood loss. And then this vault is opened at the fornix. In the same cases, how we tackle for TLH. So this is a big mass. That is the uterus along with the fibroid. All medical managements are failed in this case. That's why for the larger myoma having extension into the subendometrial region, we tackled it and then safely we morcellated inside the bag. And this is the final picture of the surgery. Now, after that, the other newer modalities, those are uterine artery embolism, MR-guided focused ultrasound, or radiofrequency myolysis. I don't have any experience regarding this. Just I put as just to complete this topic. So thank you. Thank you so much for your patience listening. And very much thank you to Solapur Vijaya Society, Bardhan Madam and Sir for inviting me here. And thank you so much to all of you for your patient listening and tolerating me since last more than half hour. Thank you so much.
Thank you, sir, for an excellent presentation on all about myoma.
Any questions from audience? Thank you, sir. I request our chairperson, please felicitate Dr. Vaman, sir.
I request Virkar sir to please felicitate our chairpersons.
Thank you for cooperation.
Please accept apology from our president, Dr. Anjali Jama ma'am, as she is unable to attend the CME because of some health issues. She convey warm welcome to the faculty and blessing to the CME. Thank you, ma'am, and get well.
Thank you. Let's move towards the panel discussion. And panelists. Tirankar ma'am. Dr. Tirankar ma'am, she is a very good teacher. She is HOD at OBGYN department at VM Medical College. From Milin Shah, sir. Actually, sir, don't have any special introductions. His special interest in high risk obstetrics, laparoscopy, ART. Sir visited almost whole world to deliver lectures on various topics in OBGYN. Thank you, sir. Thank you, ma'am. Over to you.
Yes, you want to invite the panelists as well? You can do that. Meantime, we'll just start our.
सरांचा लोड करून देतो.
बरं.
I invite Dr. Smita Chakute ma'am, Dr. Vaman Godke sir, Dr. Shashikant Umbardhan sir, Dr. Shraddha,
Please be
Dr.
trying
Poonam
to
Bundada and
come
Dr.
on,
Aditya
get your
Khurd as a panelist.
हे खालचं खालचं. ओपन
व्हिडिओ
नाही ओपन व्हिडिओ आहे पण ओपन करते ना डायरेक्ट तर त्यात आपोआपच व्हिडिओ
पॅनलिस्टचा लावतो CV.
लावा की लावा माझं लावून द्या. कुणाला अजून थोडे ऑब्लिक करा. ऑब्लिक येस.
Doctors,
थोडं पुढे घेऊन थोडं घ्यायचं थोडं जाईल ना तुला बाहेर काय होत नसलं तर करणे तर होऊ दे.
एवढं ठीक आहे एवढं होईल.
चालेल चालेल चालेल. आमचं पण
I welcome all the panelists. Dr. Smita Chakote, ma'am, she is a professor and HOD of PM Medical College, and she is writer of 2 books, Know Your Skin, Look Young Forever, Non-Invasive Art of Body Sculpting, My Life, a Masterpiece, online Amazon work on a book, 100 lives had changed because of ma'am's book. Dr. Vaman Ghodke, sir, he is a consultant gynecologist and laparoscopic surgeon. Dr. Shashikant Umbardan. He is a director and consultant of Mangalya Nursing Home and Atharva Fertility Center. He is a winner of MOGS Dr. H. Deza Prize for the best thesis for year 2006 and 7. Dr. Shraddha Parsalgikar. She is responsible nutritionist, passionate about delivering out services, offering 16 years of experience in industry with recognition of performance. Dr. Poonam Bajaj or Bhutada. She is DNB endocrinology at Hinduja Hospital and Medical Research Center, Mahi, Mumbai. MD Medicine, Lokmanya Tilak Medical College, Hospital, Mumbai. Dr. Aditya Khurt, he is a consultant gynec endoscopic surgeon and IVF specialist at Khut Endoscopy Fertility Center. I request our moderator, please start the panel.
हो हो
होतेच आहे. Well, thank you very much. At the onset, I must say big thanks to Solapur Ubijivai Society. I'm so fortunate this year that many of Anjali Jamma's events I'm attending. Thank you very much, Supriya, Archana, and the entire group of the organizing committee for giving us this wonderful opportunity. Just now, when we were sitting in the audience, me and one of our very senior OBGYN and Dr. Zambre were discussing that nowadays, PCOS, we have heard so much that sometimes we feel that what new we are going to add in it. But I will tell you, friends, we have such a great expert panelist with us, and we have chosen very specific questions from them to find out what actually practically we can do in these cases. And that's why our intention is. Because we know this duo since years. We know Steen Leventhal, who was the one who always and always gave us the insight of this polycystic ovarian disease, including the wage resection in those times. But this picture, the Solapur OBGYNs, they know about it. Basically, it could be for the Vaman and Aditya. Can you identify who is this person in this picture? Yes, he's Professor Spirov, the another personality who always and always taught us about the endocrinology part in the gynecology. And that's why it's very, very important. And this is the girl who again put a lot of interest in my clinical practice, very early days of my practice, when she had come to me with this particular picture. And then again, I went back to the literature and I found, oh, such a book picture. This particular patient was in front of me, a diabetic Despema Babi. This girl, she said that she's going to quit the college because of this particular problem. I said, don't do that. You have a lot of actually the answers to your problem, which we can manage. We need to do investigations. We need to do a lot of treatment part. We have a very good cosmetologist like Dr. Smita, and she will definitely help you to get again a good Barbie-like picture as well, provided you take proper treatment. And that's how the things keep on changing as well. There is always and always answer for all those things. Yeah.
So now, what is polycystic ovarian disease, or what is called as PCOD? So this is the idiopathic or association of hyperandrogenism with chronic anovulation in women without specific underlying disease of the adrenal or the pituitary gland. The incidence seen is around 5 to 10% in the reproductive age group. The prevalence is 15 to 23%. And as we see that it is 87% of the patients who have oligomenorrhea and 26% are amenorrheic. The etiology is almost not known, with the heterogeneous disorder of multifactorial etiology, that is genetic, endocrine, metabolic, and environmental. So now I would like to put a question in front of the eminent panelists that in clinical practice, how or what clinical picture suspects us to diagnose the PCOS today?
Yeah, basically, we want to learn from you how you will diagnose PCOS in a given case. Anyone can take that, yeah. See, all questions are open for all panelists because then accordingly you can choose and give your practical inputs. Yes, Vaman, you want to start?
Yeah. Basically, depend upon the patient's presentation. We used to think regarding the polycystic ovaries, most common things, those are the menstrual irregularities in young girls.
Yes.
And menstrual as well as fertility problems in married.
Yeah.
So when we started investigations,
Yes.
first and foremost thing is irregular cycles, obesity, and ultrasound pictures who are in morphology, which gives us a clue regarding the polycystic ovaries.
Yeah, very good. So Shashikant, so you are attending many of the ISHRE conferences where the ISHRE group always sit together. This was the Rotterdam who brought this criteria for the diagnosis of PCOS to us. So what is your opinion on that, about the Rotterdam's criteria for the diagnosis of PCOS and your views on that, whether still they are adopted or there are some changes in that?
Before Rotterdam, there was the NIH classification which was used, which was very stringent. It was only including the anovulation or oligovulation, along with that hyperandrogenic features. But to that, Rotterdam added the morphological signs or ultrasound pictures of PCOS, which diagnose that bilaterally when we see the more than 12 AFC is more than 12, then it is added as a parameter, and then 2 out of these 3 has to be there for the diagnosis. So it is added parameter helps us for the inclusion of this more patient to this criteria.
Yes.
Initially, before that, it was only stringent because of anovulation and hyperandrogenism. Stringent both has to be present for NIH, but now with the large spectrum where we see the obese patients are there, who are having the androgenic features, and we see that there are very lean thin patients also with a BMI of 20, but they are having anovulation, oligomenorrhea, and androgenic signs. These can be also included with NIH.
Very good. See, this is the advantage of attending the conferences, that yes, we understand this. Very true. Especially for those youngsters who are sitting on the back actually tables. See, this always happens in the examination. Probably the examiner may ask you about both these things, the Rotterdam as well as the NIH classification. And you need to have a clinchy sort of the difference between these two and why the questions were raised on this Rotterdam's criteria, because quite often there are so many actually other causes which could be having the same picture what you saw in that particular patient whom I showed you in the first slide. That's why exclusion of other causes of about is very, very important. So what other causes come to your mind? Anyone can take that, yes. Aditya, other causes of this hirsutism and the hyperandrogenism?
Of course, common is these adrenal causes which could lead to similar kind of picture. So we
Correct.
rule out them and then declare, or you can consider the patient as having polycystic ovarian syndrome.
Yes.
And no more it's a disease, but it's a syndrome where collection of many signs and symptoms leading to the diagnosis.
Very good. Yeah. Yeah. This is again a very important take home message, which is there. We need to understand that we know about the clinical picture. We know all these features which we need to see. And then we think about the ultrasound watch. Yes. Yes.
Can I add
Smita, you
one
told-
point?
Yeah, yeah,
Very
definitely.
common as a dermatologist for
Yes.
hair loss when we prescribe minoxidil,
Oh,
that also can cause hirsutism.
see,
So
this
this
is the-
could
yeah.
be drug induced as well. So we need to check in for that.
Great. So iatrogenic sort of, cause for this hirsutism as well, again, very important. But basically, one need to understand about this ultrasound picture that yes, it need to have so many things like echogenic stroma and all other things there supported by the endocrinological, actually, the findings. Yes, Poonam, do you want to add what endocrine actually abnormalities we expect? Suppose we are suspecting that case as a PCOS.
As in lab abnormalities you're asking about.
Yes, endocrinal picture, yeah, profile.
So generally, whenever a PCOS patient comes for evaluation, as we know, PCOS is a diagnosis of exclusion. We don't diagnose PCOS based on clinical scenario only. We rule out other causes and then only we diagnose patient with PCOS.
Good.
So first and foremost, when patient comes to your clinic with oligomenorrhea, hirsutism, which both can be there or single symptom can be there, then first of all, what we do, most commonly we do TSH and prolactin for that patient, because most important is to rule out hypothyroidism and hyperprolactinemia in view of
Yes.
oligomenorrhea for that patient. And if patient has got hirsutism, then we will do total, or if good free testosterone level is available with your lab, then we do free testosterone for that patient to look at the levels. If the level is in the range of PCOS or it is in the range of other malignant causes like adrenal or ovarian tumors that we see. So, and after that, if patient wants, if the patient has got both anovulation and hirsutism, then we rule out other common causes. Then we did not go ahead with USG as per Rotterdam's criteria. But if patient has only one of them present, anovulation or hirsutism, then we go ahead with USG for that patient. And if USG is saying positive, then after ruling out other causes, we say the patient has got PCOD.
Yes, very true. And one more point I wanted to ask you about this insulin label. It was a very commonly discussed thing that people used to do the fasting insulin. Personally, I never believed in that because my clinical picture was quite open enough to tell me that she's having insulin resistance. And
Generally,
probably Dr.
patient has
Smita
got
will agree with that.
acanthosis.
Yeah. But do you think that it is must to do the insulin label or we should go to the GCT?
No, actually, we don't do in endocrinology practice. We neither do GCT nor do fasting insulin level.
Correct.
Because we diagnose insulin resistance based on clinical scenario. If patient has got acanthosis, patient has got insulin resistance. Even if patient doesn't have acanthosis, we believe that most of them have, even if non-obese PCOS have insulin resistance at ovarian level. That is endocrine dictum. And there is a difference in practice between gynecologists and endocrinologists. We use metformin very rampantly because, and even in lean PCOS, if you give low dose metformin, depending on their tolerance to metformin, they do respond well.
Yes.
So, and GCT also we don't do, but if it is better to do fasting blood sugar and HbA1c in every patient.
Correct.
Because when you start metformin, you can mask the underlying diabetes status. So, and plus when you are giving an anti-diabetic drug to the patient, then you need to explain to them that this drug is not being given to them for diabetes, it is given to them for PCOS. So it is better to rule out underlying
Correct.
thing.
Yeah.
Can I add a point?
Yeah, sure.
So what Dr. rightly said is every PCOS woman has some form of insulin resistance.
Correct.
Sometimes mild, sometimes severe. The acanthosis nigricans is a very late manifestation. You may not always pick up, but insulin resistance is there, and insulin sensitizers does help these women have better outcome, especially in the fertility scenario.
Correct. Yeah.
So if they are lean, then you can give low dose metformin. If they are not at all tolerating, then some patients can be given small dose of pioglitazone as well. That way.
Very good. Yeah. So we are coming to all those sensitizers very soon. And basically, yeah, in the diagnosis part, this is very important to have the, combination of everything, the ultrasonography, clinical and the biochemical, and to call it the pakka actually PCOD, we need to meet that circle, which is again very, very important. Now, another problem which is always there is the association of hyperprolactinemia in polycystic ovaries. So what do you say on that? Anyone can take or Poonam can take that, yeah.
Okay, generally prolactin levels are mildly elevated in PCOS in all the patients.
Yes.
So generally, I don't do prolactin to prove that it is elevated in PCOS. I generally do prolactin to rule out other causes for like any pituitary prolactin secreting tumor, as it can cause oligomenorrhea in that patient. Clinically, when we see a patient, if patient has got oligomenorrhea, and if patient has got good amount of bleeding, withdrawal bleeding with progesterone, or whenever intermittently if she is getting menses and if she has menorrhagia, it is rare that patient will have hyperprolactinemia as a cause for oligomenorrhea, because hyperprolactinemia will have low FSH/LH, it will have low estrogen, and it will have a thin endometrium. Patient won't have menorrhagia for that matter. But then ruling, because it is a treatable cause of oligomenorrhea, we do prolactin level. But yes, if it is more than 100, if it is more than 100 at least, then we evaluate for cause of prolactinemia other than PCOS. If it is within 100, we contribute it to PCOS itself.
Great.
Okay, if the reports come as increase in the levels of prolactin, then the next question will be how to manage this patient.
Okay, like I already said, if it is borderline and if patient has got good endometrial thickness, increase PCOD will have increase endometrial thickness. PCOD will have menorrhagia most of the time when you give withdrawal bleeding to that patient. Then that oligomenorrhea or any other symptom is not related to prolactin level in that patient. But some patients with PCOS have got scanty menses as well. So in those patients, it is good to treat hyperprolactinemia with cabergoline.
Okay, yeah.
So which drug will you prefer?
Cabergoline only, because bromocriptine has to be taken daily. It is less effective. It is not very convenient.
Yeah. So yes, very true. Even the Cochrane review says the same thing, because they realize it not only offers the advantages, better tolerability, less side effects, as well as the main concern, which we are not going to touch today because induction part, Dr. Anil is going to cover that, but it definitely prevents that.
Whenever we treat hyperprolactinemia, I always prefer ruling out subclinical hypothyroidism, because that another is common cause for
TSH has to be done in every patient.
Every patient. Good. Yeah. See, basically, this program is organized by Acumentis. I don't know whether those people are here, but they brought maximum adjuvants in the PCOS, and people get confused because they brought, statins, they brought the berberine, they brought the folic acid, vitamin D. So, what these adjuvants are, and are they really important in the management of PCOS? Yes.
It depends on what for you are treating the patient.
Great.
First thing. If I am treating the patient for infertility, management part will be different. If I am treating the patient for hyperandrogenic features, the management or adjuvants might be different. So according to the need, it has to be changed.
Great. Yeah. See, this is the beauty of the expert panelist. The questions were shared to them, not the answers. But what we had in our mind, automatically it is coming from their answers, and that's really a wonderful part of it. Kudos to that, good answers. Yes, the purpose is to suppress the endogenous pituitary gonadotrophin and ovarian activity and to reduce the insulin resistance, and a lot of things, as I told you, are available. But basically, always in first intervention, I always call it the adjuvant. That is the weight or the lifestyle changes. And we have Shraddha with us. So Shraddha, do you want to give us some inputs on that? Because why I'm telling so? Once I was in one of the OPD of my colleague, and that lady was obese, typical PCOS looking lady. And the doctor said, जा घरी जा. पहले तो वजन बिजन कमी करून ये आणि मग तुला ट्रीटमेंट मी सुरू करेन. And then I realized, no, she's forgetting that this is a metabolic syndrome. It is not only the weight, it is some metabolic problem which is creating all that picture of the obesity as well at times. So then I realized we must tell our patients that, yes, it is important, but it has to go with the medical management as well, not only the lifestyle changes, but lifestyle changes make a 50% role. So you please tell us, what are your says on that? Yeah.
In my practice, I recommend Mediterranean diet, keto diet, and non-vegetarian diet, and intermediate fasting and meal replacement therapy. It is depend on person to person. which therapy, which diet is suited to which person. It is depend to person. But lifestyle modification has a main role in that, all that diet therapies. Only lifestyle modification, we got 30% of weight loss. In my practice, only time changes, only their habit changes. They make sure the weight loss is there.
True, very true. So it has to again individualize. That is very important. That's why we need to have the opinion of the dietitian for that. That's why, friends, even in my practice, we always kept a visiting dietitian. Nilima used to come to our clinic, and all PCOS used to go to her, because I thought they can put little more actually the added advantage of the changes. Yes, both of you, Dr.
I add
Vaman and
some
Dr.
point?
Sunita. Yes, yeah,
Yes.
please, please.
Basically, I have been into non-invasive art of body sculpting. So apart from weight reduction, it is primarily the abdominal obesity, which is a culprit for all these hormonal issues.
Yes.
So if you could reduce the abdominal girth, now how do we go about? So first step would be to break down the fat. So that can be done with the help of cryolipolysis, cavitation, and next step would be to tone your muscles. So this can be done with muscle tightening. And third is to tighten the skin. So this can be done with tripolar radiofrequency. So this also we can do mesolipolysis. So there are phosphatidylcholine injections are there. So we can give those green tea extracts are there. So mesolipolysis also works. So this is how I have been working, and I have presented papers on this particular program of non-invasive body sculpting. And this definitely helps to correct the cycles. Not only that, weight reduction, and person is in shape and the confidence comes back and they start jogging.
Great. Yeah. When you said that central obesity, suddenly I tried to take my tummy inside. But now definitely I must come to you as well to reduce my tummy. Yes, Dr. Vaman. Yes,
Yeah.
yeah, please.
Basically, when patient comes to our OPD for consultation, the approach has to be different. Like when she's obese, so like what you said, we have to reduce the weight is our first coming. So it should not be like that, because
Yes.
those patients are in some percentile depressive disorder.
Yes.
One thing. Then if couple discordant is there, like thin husband and a big fatty wife, then again discrepancy is too much.
Correct.
We have to take all those things in consideration when they come for the consultations. If we differ our opinion, then only they stuck to you. Otherwise, they will also defer the doctor, because it is very difficult to reduce the weight in obese patients. Like what if suppose they ask us what to do? They can't do the gym because they injured something. They can't run because they are obese. So at that time, we have to have the multiple consultations like diet, our consultations, start at least some adjunct, so that for a few months, she will have a good confidence in us, and then slowly start treatment for that. Otherwise, to reduce the weight and come, if you reduce 10 kg, you can ovulate and you can become pregnant, then husband will try to reduce wife's weight, and so many complicated things can occur. So the approach has to be there, and we have to spend some time with them.
Good. Yes.
Each and every patient can't be sent to dietitian in our setup. They are generally, many of them are non-offering patient. What I do is generally, I don't go ahead with keto diet or crash dieting, because these are temporary things. I generally tell them to follow a diet which they will be able to follow for their life. First of all, when patient comes to you for the first time, I tell the patient, like diabetes, BP, this is a permanent chronic disease which you have. And like if from 75, for example, 75, you would be able to go to 65, you will get a normal menses, you will get ovulation. Again, if you're coming back to 75, again, you're going to go back to that thing only. So generally in our Indian diet, what I have observed is carbohydrate is too much. It is not related to fat most of the time. So generally easiest way, if they are taking two chapati, I'll tell them to have one chapati and little bit rice. They can skip bakery item, and they can skip sugar altogether, and with little exercise it should work. Meal replacements are generally very costly therapy to continue for chronic thing. They are boring as well because they are not tasty. So it is important to give them a diet which they would be able to follow. If they lose 20 kg and again they are going to regain that weight, it is of no use to the
So
patient.
basically it is a hypocaloric diet.
Yes, hypocaloric diet, yes. And a normal routine diet which they can follow easily in their usual practice.
Yes.
Yes.
Dr. Poonam, what's your experience of giving metformin for weight reduction? I have tried in acanthosis nigricans whenever we give in civil hospital. They invariably, the pharmacist in the civil hospital says, Madam, isko diabetes hai kya aapne metformin de diya?
Yes.
You know, so I want to know what is your personal experience. I've read papers, but I would like to know what's your personal experience.
When I write metformin for PCOS patient, my first line would be, this drug is also used for diabetes, but I'm not giving you for diabetes. This is for PCOS. And metformin causes good reduction in acanthosis nigricans, but it doesn't cause weight loss in obese patient most of the time. If you're giving to lean patient, they will lose weight unnecessarily, and if you're giving to obese patient, they won't lose that much. Mainly diet works. Metformin would cause 2, 3, 4 kg. It depends on patient to patient. It varies. And if metformin is causing weight reduction in that patient, generally in those patients, they will get GI side effects or loss of appetite or nauseating symptom. In high dosages, it is not tolerated well. So with diet, exercise, for insulin resistance part, we can use metformin, not most of the time for weight. We are not giving it for weight reduction. If we want to give for weight reduction, we can add orlistat. Liraglutide is little costlier. If offering patient is there, we can think of liraglutide as well.
Great, yeah.
Zamre madam wants to
I
add.
want to just know,
Yes.
and in a clinical practice, when we see in patient who PCOS especially, take very long time. It is very difficult to reduce the weight in them as
Yes.
compared to the patient who are non-PCOS.
Yes.
If suppose patient is obese who is not PCOS, we find that the weight reduction become easier.
Yes,
Here
that
it is
is
what you are
because
saying.
of insulin resistance.
that's-
They have got hunger pangs and they have got sugar
Yeah,
cravings.
because
So
it is very difficult.
yeah.
It's easy to tell them that 5% of your total weight should be reduced. But we find a month together they don't hardly, they really do take a pains to reduce
Pains
the
to
weight.
do that, yeah.
In spite
See,
of that,
that's why I told you this story, which I heard in one of the OBGYN clinic when they said, "जा घरी जा आणि वजन कमी नाही." तो metabolic syndrome आहे समजून घेतलं,
Exactly.
it's always better, you know, then we can do simultaneously
If we
with
give
all
3-4
the.
months of orlistat to the patient, now that patient will get a push. Yes, I'm losing weight, so we'll put some extra efforts to lose the weight.
Yes,
So it is better to give some weight loss therapy for 3 to 4 months. Then you can start after they start.
Correct. And even what Dr. Waman told is again true. Already they are worried about their weight, and you know that suppose we add on that, you know, emphasizing on that, it becomes a very difficult situation.
I think
Yeah. Yes.
weight is one of the very important components of PCOS. The very fact last 10 minutes we are stuck on this slide is
Yes.
because that is the whole soul of PCOS, one of the very important. Now, as everybody has discussed, it is a big challenge for the consultant and more importantly, the patient. It doesn't come down. But then in that, we have to find a middle way out. The middle way out is patience. You have to spend some time with the patient. Many a times give example of your conceived patients to them that they lost few kilos over a period of time, simultaneously add adjuvants.
Yes.
So together, if we help the patient, it will help them reduce their irregularities, help them conceive. And so many times I've seen our focus is on exercise and we forget 80%, which is the diet. So many times they are eating more of carbohydrate, even if they reduce that chapati, they reduce those bakery products. Along with that, starting small amount of exercise and small targets, it helps and gives a
Ask
good
them,
outcome.
most of them would say they would don't eat much.
Yes, yes.
But then when you ask them, 5 रुपए का biscuit packet मैं रोज खाता हूँ सुबह शाम, that they will have, everyone.
I think so. Dr. Monica should receive a good round of applause because she has done a wonderful makeover. And I think so she should share her private experience. Yes, where is Monica?
Yeah.
I just congratulated her. No sooner I entered.
And most of us are on. Archana is also doing the same diet, and Vaman sir is also following the same diet.
It's coming in the flow, ma'am.
It is as good as intermittent fasting, ma'am, as what Poonam madam has said, and it is basically reduction of carbohydrates in your diet, and 60% has to be vegetables and salads. And it is 2 principal meals. Rest of the day, it is like intermittent fasting. You can have tea, coffee, cucumber, tomato, or buttermilk. The rest of it, it is nothing
Good.
without sugar. Without exercise,
But
patient
are
can
you going
lose
to
weight,
apply
but
that for the
without diet,
husband
patient
as well?
can't.
Okay, great. Yeah. Yes. Yes.
So this question will be specific to Smita. What are the various skin manifestations in PCOS?
Yes, many a times we have young girls coming to us. The first problem is acne. In spite of giving doxycycline, azithromycin, they don't respond. So they are resistant acnes. That's the first thing. Second thing, they complain of dry hair. They complain of androgenetic type of alopecia. So it's a central parting of the hair, which becomes wider and wider as days pass on. And the third thing, what we see is acanthosis nigricans. Fourth, they tend to have a monkey-like faces, like what we call it as seborrhea. So the skin becomes extremely oily and especially in this perinasal area and perioral area. So that is seborrhea. And common finding along with that, what we see is acrocordons, acanthosis nigricans, and obviously because of obesity, you see stretch marks. There are very few things associated, as Dr. Shah sir said. PCOS is a metabolic disease. So along with that, invariably, they'll end up with psoriasis because psoriasis is also a metabolic disorder. Many a times, premenstrually, these patients see a flare of eczema. So that is one more common finding which we tend to see. They clearly say that just before my menstruation, my eczema, I really scratch very badly. So that is one more finding. And dry skin. So these are the commonest OPD features which we see in our consultation.
Yeah, great. Any about the medications, you want to add anything? Anything specific you practice?
Basically, for the acne, as the primary thing is, again, we ask for a weight loss. So how do we go about with weight loss is I ask them to stop their carbohydrate in the night. That's one primary thing. Ask them to eat before 7:30 and avoid all the bakery foods. So this is how simple advice which I give. And next is exercise. And along with that, whatever medications and procedures, cosmetic procedures we do. But if there is central obesity, definitely, as I told you, sir, we go in for non-invasive body sculpting, mesolipolysis.
Correct.
So that also helps. And for androgenetic alopecia, here we never use minoxidil because they are PCOS. They will be having more amount of hair on the chin and the cheek. So we usually go for procapil local application rather than minoxidil application. So that is for a hair. And apart from that, definitely we have a spa. So we go for a good hair massage for the dry hair. And acanthosis nigricans, as ma'am already said, we go in for metformin.
Yes.
And then myoinositol also with folic acid, those sachets are available. So definitely they also work.
Great.
Yes. So folic acid will be useful for cosmetic as well as for fertility point of view. So anyone can throw light on folic acid other than skin.
We routinely, any patient who is going for fertility, we do start them early. It
Yes.
corrects their deficiencies and helps prevent pregnancy related issues also.
Correct. Yeah. See, basically again, Spiro.
And along with that, we all know that there are neural tube defects and all that.
Correct.
But in PCOS patient, folic acid levels are low. Second thing, if you are giving these patients metformin, in those patients, the homocysteine level will increase. At the same time, their folic acid and B12 level will go down. So these patients will be having poor quality oocytes. So for them to add the little bit of folic acid, 400 microgram whatever we use, will improve the oocyte quality.
Yeah. True. Suppose you again go back home and open the book of Professor Spiro, you will find in those days, he has written, those days ART was not very practiced routinely. But he wrote that these oocytes of the PCOS are incompetent for the reproduction because of their quality, their maturation, implantation, and placentation. That's why this sort of adjuvants could be of use, provided, as Shashikant told very correctly, this is important. The another actually the vitamin which is again used very common is the inositol. So any comments on that? Myoinositol or the other inositols?
There are multiple inositols. There are
Yes.
9 isomers available. Myoinositol and D-chiro, whatever is But personally, if you will ask me, this is pharma hype things
Okay.
which are used in infertility practice. I'm talking about infertility. I'm not going about the rest of the features of PCOS. But inositols are available enough in our bodies. Yes, sometimes if given along with in severe obese patients with metformin, it can help in ovulation in these patients.
Okay. Yes. Vaman wanted to add something. Yeah.
Shashi answered correctly, but still the papers are there that inositol and all in polycystic ovaries, they improve the oocyte quality and mitochondrial functions. So, as in adjunct drugs, one can use the inositols also.
Yes.
The food agents which have these myocytonol agents are basically citrus fruits. The very simple thing is just soak 4 almonds in the night and eat 4 almonds. Walnuts are good source and whole wheat is also good source. So if you don't want to follow any of this, pressure of this medical representatives, this is how I go about. Give a simple diet and that will really work beautifully. And your skin also will start glowing.
Yes, Shraddha, you want to add something?
Almond peanut butter is also good source of that.
Okay. Yeah. Yeah. Good. Good.
If
good.
you see the literature, so many of our food items only contain myo-inositol. So in our practice, usually I focus more on metformin.
If patient is not tolerating metformin, then there is a role. If it mainly reduces insulin resistance, but metformin is a much more potent drug. When you are already giving metformin, there won't be any further use of inositol, etc.
Great.
Time-tested drug over a period of so many years.
Yes. Recently, I saw that one advertise on the Instagram where Siddharth, I think he was telling about this peanut butter. And he said that is the best one after you are gymming to have the better thing. Yes. Basically, very true. Everyone said so. See, these are the actually both way working agents, the insulin sensitizers, and they work through this PI3 kinase activation process. And that's how the myo-inositol could be of use those who cannot tolerate the metformin. Again, I will tell you one very interesting story about the same. One of the radio jockey from our own city having long-term infertility, 11 years. She considered with us both on metformin for her PCO. And we told her that time, you need to continue it for another few months, at least for, pregnancy related problems, which we are going to discuss in coming slide as well. She said, no, I'm not going to use. Have you ever ate metformin? Very leading question. I said, no, I never got a chance. She said, it's so difficult to tolerate. And probably in these subjects, myo-inositol could be some answer to them for taking care of those things by taking into consideration. And there are n number of papers, as Vaman was telling very correctly, evidence-based actually medicines, which we need to again adopt very cautiously, but they could be of some use in the cases of where we need the insulin resistance to need to be tackled with the other problems. And yes, there is always a comparison between these two. Yes, you want to tell about this comparison? Yes.
Comparison between myo-inositol and metformin. So it has been seen that myo-inositol and folic acid, it increases the P13 kinase production, whereas metformin does not increase, and insulin action is improved by 80% when given in combination, whereas with metformin, the insulin action improves by only 33%.
Yes. So this could be the another thing. Yeah. Yes. Now, see, suppose I will do the vitamin D levels of all of you. I'm very sure 90% of us have a vitamin D deficiency. So any say on that? Shraddha, you want to tell about this? Does it have any role in the PCOS?
Yes.
Yes.
Vitamin D sources are naturally there, sunlight, but now we are all in ACs
Yes.
and in one room. So that other sources are cow's milk, sprouts are there. I suggested sprouts in breakfast, cooked sprouts. It plays mostly role in weight loss also and vitamin D formation also.
Great. Yeah. They say about the sunlight, but again, a lot of controversies. What is your say on that? How to utilize that sunlight for vitamin D? In which day of the time of the day?
It is 7 to in morning.
Morning,
and
yeah,
in
correct,
evening.
correct, yeah, good, yeah. So basically, we need to take this particular fact into consideration because we
Generally,
know.
the amount of exposure which they ask for our ethnicity patient, we are dark skinned people. So for other Caucasian people and American people and all, generally 1 to 2 hours will be enough. Then when we see for ourselves, they are recommending like some studies are 5 years, 6 years, 8 years, which is not practically feasible. So rather than checking vitamin D for everyone, it is better to give it to everyone.
Yes.
Now, and there is lot of difference between the deficiency normal level and toxicity level. Rarely with oral vitamin D, you will reach to the 200 level, which is a toxicity level. So it is safe to give it to all.
Yes, yeah.
Nowadays, whatever the medications we used to prescribe is fortified with vitamin D3. So no need to give it
Fortified,
separately
yeah,
also.
absolutely.
Is any experience on these other adjuvants?
Melatonin, alpha calcidol, chromium, berberine. Anyone has their own clinical practice says about that? Yes.
These are the adjuvant drugs, melatonin, particularly for the oocyte development, maturation, basically acts on the mitochondrial levels.
Yes.
Melatonin, then
Berberine.
berberine hydrochloride. It is there nowadays saying it is an alternative to metformin again, which increases the insulin sensitivity.
Correct, very true. So these two core problems one need to understand: decreased insulin receptor expression and decreased dephosphorylated AMPK activity. Suppose we understand that, very true, as Dr. Bahman says, we'll have to choose it from that armamentarium, whatever is needed for that. But basically, the main idea is whatever is available need to be again managed with the cost factor as well, because quite often these adjuvants may be little expensive as well to take care of this AMPK activity. I'm just going to skip this. Yeah. Yes. Now, coming to the thing, yes, as Poonam was telling about the investigation part about doing vitamin D. See what we have started. Nowadays, many laboratories are actually, they are at a doorstep. Quite often, they give us some profile, like vitamin profile. Hardly few actually rupees, and we can, have the entire list. So does it really, helps? Because otherwise, suppose we do individual vitamins, it becomes very expensive. But suppose I do the PCOS profile, the vitamin profile, it's hardly 500, 600 rupees, but we get entire idea to choose these various adjuvants. So what is your say on that? Whether we should go with those profiles or we should do the individual vitamin levels, how you practice?
Profile depends what the profile includes. Basically,
Yes.
it depends on the lab. So
Yes.
it should be specific.
Correct.
And if you want, if you have got some protocol, you can make your profile like that. I don't
Yes.
know what your profile includes.
Yeah, basically it covers the the lipid levels, the vitamin profile, and the hormonal endocrine actually profile, and it becomes so cheap, that we also bit happy, patient also is bit happy, and
No, but they are not very cheap, sir. And FSH, LH is not required. Testo is needed. TSH prolactin is needed. Androstenediol is not needed. DHES is not needed. Many of the profiles are
Have
they are
additional things,
including
additional
all the
things.
androgens, which are not
Yes.
required.
Yes.
And they won't help in treatment as such.
Correct. Yeah. Good. Yeah.
Something which is clinically evident, then you did not have to confirm biochemistry and start your
It is
treatments.
individualized. If patient doesn't have hirsutism, why to do all the androgens?
Yes. The another very commonly rather neglected problem is about especially obese, actually PCOS, is dyslipidemia, which always said that central role in the pathogenesis of PCOS through this HMG-CoA reductase activity, which is the rate limiting enzyme, and which causes actually the problems. And that's why people started using statin. In fact, I think we got a question online as well from Dr. Saman about the statins. So what is your say on that? Whether the statins are useful in all cases of PCOS, or you will restrict it in the cases of dyslipidemia?
As such, we are using statins in PCOS for dyslipidemia only. We are not
Yes.
using it for PCOS as such. And one more thing, statins are not safe in pregnancy.
Yes.
So while asking for lipid analysis, I only ask when patient is not planning for pregnancy. Anyways, we are giving diet to that patient. Anyways, we are trying for weight loss modifications and all. So only if you will be able to add statin, then you do lipid profile. Otherwise, there is no use doing.
Yes. Or maybe what I feel, actually what we do in our clinical practice at times, as we are not routinely using statins in our day-to-day work as OBGYN, we always take a help of our cardiology friend. And then we take a call because we understand, as you told very correctly, it is not totally safe as well, causes a lot of muscle weakness. And that's why one need to, use it again cautiously. But there are again n number of actually papers which tell about this. As you can see here, they say that it definitely helps as far as the lipid changes which are there in these cases of PCOS will get improved, and even the cholesterol levels as well, and could be of some use as well.
Plus, mild dyslipidemia might respond to metformin as well, because it is basically because of metabolic profile.
Yes.
But if it is severe, like if LDL is more than 160, if patient is not planning for pregnancy, then it is better to add statin.
Correct. Yeah, true. About the ovulation induction, we have purposefully skipped those slides because we understand that that is going to covered very extensively by none other than our very close friend, Dr. Anil. But the drilling, he's not going to cover the drilling. So I thought, what is your say on that? Because it was a very routine practice in certain period of time before we understood the role of AMH and the ovarian reserve, poor ovarian reserve. People used to put the scope and they used to drill the ovaries. So what is your say on that? All of you can take this question, whether you will prefer to drill all those patients of PCOS or you will restrict to certain group. Yes. Let us start with Aditya. Yeah.
Now, with good ovulation induction medicines available, especially letrozole, the role for laparoscopic ovarian drilling has definitely reduced, because so many of the patients who are facing anovulatory infertility respond very well to increasing doses letrozole. They conceive and need for drilling does come down. But in very, very selected cases, patient is staying remotely, not able to follow up. There is failure to conceive after oral ovulation induction. We do still offer ovulation laparoscopy with drilling for very selected kind of patient, and drilling to be done very judiciously and not drill and char the whole ovary. That is important.
Good. Yeah. So yes, the main advantage is this one-time treatment in the patients who are not able to come for the follow-up regularly. When you presume that, probably yes, but again, taking the due consideration what actually her endocrine picture says about, we'll have to utilize this tool very carefully. Shashika.
For
yes, yeah, yes, ma'am.
drilling, if you ask drill or not, answer will be not.
Yes.
And so this is the straightforward answer rather than moving around.
True.
And what is the indication for drilling nowadays is considered is not the bulky ovaries, and there is nothing like bulky ovaries. It has to be mentioned in size, particular parameters. What is bulky? Nobody knows.
Yes.
So again, it has to be correlated with the AMH levels. And if patient is more prone for OHSS, then few punctures may be advised. But again, with slow dose chronic profiles, one can select good number of follicles. So again, it is excluded. So better way to avoid it rather than going for drill.
Yes. Yeah, it's always debatable.
Sir, can I add? So as both of them have said already, it is the second line of management, not the first line of management. As you correctly told, sir, the patients who cannot come for the treatment, but again, those patients has to be resistant to the letrozole, has to be resistant to the CC. They are not ovulating at all. They are chronic androgenic patients. In those patients, it might help. To avoid the litigation, as Vaman has said, it is better to do the AMH prior and 2 to 3 months after the drilling. Nowadays, I'm seeing a lot of patients where the patients has been drilled and they are there for oocyte donation for us now. Because the AMH of this patient dropped down less than 1 once the patient has been drilled, as he has said that there are only signs that on laparoscopy, I am seeing the bulky ovaries, so just drill the ovaries and then the patient lands up in oocyte donation. So that should not be done. Simple ovarian drilling can also be of some help in some cases, or ultrasound guided ovarian drilling. I will just share 2 cases where I have done oocyte pickup for this patient. First case was 19 years infertility, AMH of more than 15. We have done ovarian pickup and embryo were frozen. To our surprise, as this was a hyper responder, we have gone for the FET. But to our surprise, in 2 months' time, when she came, she was pregnant.
So this is a very debatable question to do or not to do.
It was the punctures which we have done that has helped her after 19
So
years to
whether
conceive.
that was,
That
whether it
was
was,
done.
yes, whether it
That was
drilling.
useful in her case.
Yes.
She was a chronic androgenic patient who was not at all ovulated. On laparoscopy, we can see how are the ovaries. If there is smooth glistening surface, we can't see any signs of ovulation. Sometimes 3 or 4 drills in these patients with the 20-30 watts pressure current, which might help, but drill more than 4 in such patients are useless.
So what is your view upon needling? Whether it should be drilling or
Excellent, ma'am. This can help. It has helped for my 2 patients where I have just done Oham Pickum, they have considered in between. And those 20 embryos of those patients are lying with me. Now as frozen.
When you puncture the ovaries and for some other reason, if you put a scope, you can find those drilled holes as a black spot on the ovaries. So
Yes.
ovaries are permanently damaged at that places. One thing. And as Shashi and Sir, both are the leading IVF consultant. So I want to ask question or just share your experiences that in cases of suppose AMH is 20 and that's why some person drilled the ovaries and now AMH is 4 or 2 or 3. But at what patient used to think that the AMH level is normal now, it is 2 to 4 normal, but they won't get any follicles because for that lady the normal level is 20. So at that level she may get some follicles which she can't at the normal levels because of drilling and the cortical damage because of the
So this drilling is a wonderful tool, provided it is done very accurately. Otherwise, yes, what Mohammed says is very true. It can cause more side effects rather than the advantages. Actually the thought which many of the OBGYNs or the scientists they thought about, they found some change in the endocrine milieu of that particular ovary as well as the body. And that's why they were thinking it could be of use. Because quite often they found a study where they said this PCOS where drilling was done, the pregnancy loss was comparatively lesser because of the change in the endocrine milieu. So anyone, you can also take mom on this. Are you worried of pregnancy loss in the PCOS? What is the exact relation and what are the preventive measures we'll offer for that?
in cases of PCOS,
PCOS.
basically the oocyte quality is compromised.
Correct.
That is the most common reason. And others, those are the hormonal related factors. And the initial placenta or the corpus luteum which used to form is also a defective in these cases. So chances are more.
Yes, yeah. True, very true. So we'll have to take care of that as well. Now, the last question for the, again, all panelists, long-term health implications. Quite often, people think that it is related to only reproductive age group or the very young patients, adolescent for cosmetic or the younger patients for the infertility. Are there any long-term implications? And then whether we'll treat this PCOS at any age? Yes, all of you can take this, yeah.
Important long-term health implications, which I have also practically seen, is the hyperestrogenism is the cause leading
Yes.
to endometrial thickening,
Correct.
hyperplasia, and of course, endometrial cancer in the long term. That is
Correct.
one of the implication. And these are women who have risk for developing diabetes, metabolic syndrome in their 40s and 50s. So I always give a very advice to all the patients, maybe fertility or non-fertility gynec patients, that ensure, especially young girls, that you menstruate every 1.5 months, because whenever they are not menstruating, it is unopposed estrogen action,
Yes.
which later on leads to hyperplasia and carcinoma. Very practical case which we handled this year, last year and this year. Typical history of anovulation, irregular menses, and twice the endometrial biopsy showed features of adenocarcinoma could not be ruled out. Fortunately, we suppressed her with medical management. She conceived and she delivered a baby. But again, she has developed similar problems. But we have put her on medical management again for the hyperplasia. And the last report is normal now. So these are very common. I mean, these are problems which happen in the long term in women with PCOS.
Yes. So this is very important. This unopposed action of the estrogen can lead to the a lot of actually neoplastic changes as well. And this is again very commonly seen. That's why you will be surprised to know in the radiology book what one of the radiologists said, that whenever they find the endometrium more than 2 centimeters, they label it as the carcinoma in situ. And that's why the basic purpose is not the same with what we see in our practice. But this endometrial thickness need to be controlled, and we need to do the lot of counseling for that. But quite often, sometimes our counseling also fails, and patients, they fail to take the proper treatment, and they come repeatedly with the endometrial hyperplasia. Yes. So friends, to conclude, it was the adolescent period, reproductive period, as well as the menopausal period, where we need to address the PCOS very, very aptly and with judicious use of whatever things we discuss in this last, actually the 1 hour. So the counseling always starts from adolescent, but the best, area where we find the infertility clinic definitely gives a more chance for giving the good counseling about this particular thing. I'm going to pose certain questions for the audience as well, because they will find more interesting for that. Quiz questions, quick 5 questions. Yes. Vidya, you want to start with this? Yes.
Yes. What
You
are
can
the
quickly answer that. Yeah. Not very difficult.
So the questions are put up. So what is the criteria used in the diagnosis of PCOS, which include all of the following except?
Yes, fast. The youngsters, where is Nayan, Soumya? Come forward. See, we are going to come at the examiner. Vidya is going to come at the examiner to you. See, okay,
Right.
great. Yeah, good, good, good.
Second question, which of the following is false concerning PCOS? Yes.
Yes. D. Correct. Yes, yes.
Third question, what are the findings associated with PCOS, which include all except?
Now this examiner is Dr. Smita. Yes. Yes, yes. Dr. Smita, you tell. Okay,
I
great.
think last question, long-term sequelae associated with PCOS includes
Great.
except
Yeah.
it, yes.
Yes, great. Yeah. And last question. Yeah.
Differential diagnosis of hyperandrogenic anovulation includes all except
Yes, very good. So I'm very sure all those students sitting in the audience are going to get the good marks in their examination, because we know that these are controversial subjects in our
100%
practice. Yes. When a subject ceases to be a subject of controversy, it ceases to be a subject of interest. What William Hazlitt said, and that's very apt. What we need to do, we'll have to choose the things properly whenever there are so many things available in the clinical practice. A lot of combinations are available, as you can see in this particular video. I'm very sure will definitely make you little, relax as well to understand how many combinations can be utilized. Because they don't waste a single minute of their smoking and drinking. So friends, thank you very much. I must say big thanks to the again SOBG for this opportunity. This was a great opportunity for me to have a dais shared with none other than Vidya, who is my classmate since 11th standard. And now after so many years, we were together. Now I must say big thanks to our panelists as well. So expert, so apt, so precise, that everything was so interesting. Though it was a PCOS, again, very, very commonly churned topic, became very interesting because of your expert opinions. Thank you very much. Thank you. Thanks a lot.
Thanks for patient listening.
Thank you, sir. I request our moderator, please felicitate our panelist. Dr. Smita, ma'am.
Yes.
Dr. Vaman, sir. Dr. Shashikant Tumbadan, sir. Dr. Shraddha. And Dr. Poonam Bhutada. And Dr. Aditya, sir. I request Dr. Nanda Magai, ma'am, please felicitate our moderator. Let's move to the next session. I invite Dr. Sampath Baldava, sir, and Dr. Sulba Zamre, ma'am, to chair the session. Dr. Baldava, sir, is senior most consultant of our town, great academician, director of Baldava Hospital. Dr. Sulba, ma'am, she is senior. Dr. Sulba Zamre, ma'am, she is senior consultant. Age is just number for her. Very friendly and motherly attitude, ever ready to help to everyone. Over to you, sir and ma'am.
Should we start? Acha. We had good afternoon to everybody. We had just now had a lot learn about PCOS, and we know the problem remains same in spite of listening so much when we are treating the cases of PCOS. Now we have a very talented person to us who will be Dr. Anil Gudi, who is a consultant in assisted conception and reproductive medicine. He'll be joining with us on the Zoom. We have heard him many times in lot of infertility sessions, but I think he will be throwing a lot of light on the induction of the ovulation in the patient PCOD. As we know, he's joined? Yes.
Hello, can you hear me? I can't You've disabled my screen sharing.
So you can try now.
Okay. Yeah, can you hear me now?
Yes, yes, sir. Good
Hello,
afternoon, sir. Welcome. Yes, good afternoon. Welcome. We are very eager to listen from you, sir. Please.
Thank you very much, and good afternoon, and thank you for inviting me to lecture. Sunday morning is not the best time, but anyway, I'm getting older, so I wake up much earlier now. I believe that you had a lot of discussion on PCOS, and it's a subject where we often claim that we see a lot of it and we know how to treat. But I think it's one of the areas where we are still very much in the unclear. We see a huge changes that are a generational away, which means that the generation that is teaching you is not a generation that follows the same diet, which basically means that the living pattern has changed. So the younger generation is eating and probably living the lives which we have not lived. And we are trying to understand how that happens. And all that has a metabolic aspect to it. So if you have time, then have a look at the phenotype paper, which Sachin Kulkarni and I conducted in Maharashtra. And that was one of the first phenotype papers demonstrating that Indian PCOS is very different, and its link to metabolic changes is entirely different. And I don't think at present we have any other study which looks at that. So let's go back to the old definition, and which has been used is, let's look at the revised diagnostic criteria. That's Rotterdam. 2 out of the 3 you should have ovulation or anovulation, hyperandrogenism, clinical or biochemical, and polycystic ovaries. Very simple, and that was with all the etiologies. And we think that 20% of the Caucasian population has polycystic ovaries, and probably about 30% we think of the Indian population has polycystic ovaries. And 5 to 10% of the women suffer from symptoms. So, let's go slightly different. You'll find this talk somewhere on now fertility courses where I teach, and it's freely available to everyone. So let's look at going slightly away from the old classification, because the old classification does not tell you much about the type of polycystic ovaries. It just tells you a diagnosis, and it's quite a vague definition. So, what are the main features? And the main features are hyperandrogenism, so let's call it HA, ovulatory dysfunction, and PCO morphology. And it's a heterogeneous disorder. And 3 different criteria have been set. The National Institute of Health has a criteria for PCOS, the Rotterdam has a criteria for PCOS, and the Androgen Access and the PCOS Society also has a definition. So if you have a look at it, there's a plus or minus everywhere that goes on. So there's no clear, straightforward consensus into what is PCOS. And that's the reason why going on to a phenotype is a much better way. So let's look at what the phenotype says. Phenotype A is hyperandrogenism, ovulatory dysfunction, and PCOM, an ovary showing polycystic. Phenotype B is hyperandrogenism and ovulatory dysfunction. Phenotype C is hyperandrogenism and ovaries are like PCOM, which means they are ovulatory PCOS. And phenotype D is ovulatory dysfunction and PCOM. So if you have a look at it, you will see many of your patients are falling in one of the criteria. For example, phenotype B is you will see irregular periods. Ovaries don't look PCO-like, but there are signs of hyperandrogenism. And this is also a type of PCOS. And it is time that we start looking at changing our diagnosis and our treatment to a phenotype. So, which phenotype is probably going to be the most challenging? It's going to be phenotype A. Why? Because there is a significant metabolic change. And if you start looking at this way of phenotype classification, you'll understand PCOS slightly better, or maybe your way of looking into treatments is slightly better. So type A and type B are complete PCOS phenotype, and they are referred to as classic PCOS. They're more hirsute, obese, they're more likely to have insulin resistance, and there's an increased risk of metabolic syndrome. Now, you have polycystic ovaries, and that's phenotype C, and you're looking at ovulatory PCOS, and that's without an ovulatory dysfunction. So you'll see signs of hirsutism maybe, and PCOS, but you're not going to see ovulatory dysfunction. And there's non-hyperandrogenic PCOS, and that's phenotype D, where you don't have hyperandrogenism, and normal androgens, mild degree of endocrine dysfunction, and it's the mildest form of endocrine dysfunction, including metabolic. So that, if you start looking at this, you'll realize that PCOS spreads over a wide area, and going to the old definition sometimes is not going to give you all the ideas. And there's significant differences. Phenotype A is what you'll often see. Phenotype C is most common in unselected populations, which means in women who don't come to you with any complaint. Those are the population where you'll see phenotype C. So at the end, using this will need further, a discussion. So what's the treatment? And we'll say, well, if you're obese, lose weight. Why? Because a loss of more than 5% of body weight reduces insulin levels, improves it reduces androgen production, and reduces free testosterone. It induces ovulation, facilitates ovulation induction, and reduces miscarriage rates. So that's good. That's good. Now, so if you look at the Indian PCOS, a significant part of the Indian PCOS in the villages and towns is lean PCOS. So if you are going to ask them to lose more weight, you're going to switch off their pituitary gland, and that's what you're seeing in cities where you have women with PCOS who want to get down to a slimmer size. So even with PCOS, they are switching off their pituitary gland. So you see a combination of hypothalamic amenorrhea along with PCOS. And believe me, you'll see more of it more and more as you start seeing young girls who are desperate to lose weight, and in that aspect. So let's go to treatment, and we'll say, let's go step by step. And let's say, let's go to oral agents, then we go to injectable. It's a long talk, so each of this is about an hour and a half talk when I normally do it. So I'll try and compress it within the hour. So clomiphene, and what does clomiphene do? And clomiphene, I think, has made a comeback, and I use it extensively in IVF, and since I'll probably try and explain at some other time how it works. But if you see what clomiphene does is it causes estrogen receptor depletion at the level of pituitary and medial hypothalamus. And so the negative feedback is centrally interrupted, and the FSH secretion keeps on increasing. So in simple terms, I tell my patients, clomiphene fools the pituitary into believing that it needs to give more FSH by blocking its receptors. So when do you start it? You can start it on day 2, day 3, day 4, day 5. It doesn't make any difference. And you start it with a dose of 50 milligram, rising to 50 milligram if there's no ovulation. And we know that beyond 150, it doesn't seem to be useful. And so it probably needs to be stopped as a treatment. Now, how long can you give Clomid? We think 6 ovulatory cycles. And a majority of the pregnancies seem to occur in the first 3 months of treatment. Now, the entire question about whether clomiphene causes cancer has been proved to be wrong. And that was based on a very, very poor set of studies. And I don't think that can be quoted at present. So can you give it for more than 6 cycles? You can, but with newer drugs available, I don't see the point of continuing clomiphene much longer. The question now comes up is, should you give HCG in clomiphene cycles? And people say, should you give it? I'll say give it, because it makes your life simple and it makes the patient's life simple. But let's look at all the evidence, and the evidence says probably we don't know. We don't know the answer whether we give clomiphene or not. So in my personal practice, I'll say, well, give clomiphene, give HCG, because it will at least give you a very clear idea about ovulation. So it helps couples to time sexual intercourse, but also, as it's a long-acting aspect, it provides a certain amount of luteal phase support in the early luteal phase, not in a late luteal phase. So it has its benefits in doing that. So why does clomiphene fail? And clomiphene fails at two ways of looking at clomiphene failure. One is there's clomiphene resistance, which means that the ovary fails to respond to clomiphene. And the other cases is a significant number of patients have ovulation. So it successfully helps you, the women, to ovulate, but there's no pregnancy. And that could be due to the anti-estrogenic effects, cervical mucus, endometrium. And remember that clomiphene always keeps baseline LH levels that are high, because the pituitary releases both hormones. So you'll see a slightly higher LH levels. But the surprising thing is that if you give clomiphene from day 1 to trigger date continuously, that's what we do in mild IVF, you very rarely see premature ovulation. And you see it in about 2% of cases. So it's a phenomenal treatment if you're going to use it for mild IVF. The question now asked is, can you give it for unexplained infertility? And the answer is, if you want to. Patients come and say, I want some clomiphene, I've got regular cycles, and your logic is more follicles, better pregnancy rates. But almost every research done on this, even the recent one, show it doesn't seem to work on its own. Maybe with intrauterine insemination, it may be possible. So how do you improve results with clomiphene? One, decrease insulin resistance, weight loss. If there is anti-estrogenic effects, mucus, endometrium, then stop it and go for another drug. Don't decrease the dose. Don't try and give estrogen. Don't try and do something because evidence suggests it just does not work, and it's time to probably upgrade to treatment. Do you give HCG? We don't know. Estrogens, again, it does not seem to help. It makes you feel better. Dexamethasone, very dangerous to use. It can be used generally with adrenal hyperplasia, but if you use it, and I've seen people use it in IVF in a stimulation cycle to lower the androgens, but it has quite significant side effects over a long period. And finally, we come to the favorite drug called metformin. And so we'll talk about metformin. So what happened in 2007, Richard Legros came up with a paper that was the first trial of metformin, and basically said that if you give metformin, what happens? And they found that metformin on its own is pretty useless for ovulation induction, but combining clomiphene and metformin was useful. So we started looking at the recent evidence that metformin does seem to improve the rate of pregnancy, especially in cases of resistant PCOS. So if you have, and I always say that is, if you have irregular periods, as soon as periods are irregular, I call it metabolic. Why? Because the irregularity of period is a sign that the ovary is finding it immensely difficult to work. And why does it find it difficult to work? Because of insulin resistance. And in those cases, adding metformin to your treatment seems to make helps. And so almost all the studies are looking at saying, yes, metformin does help in resistant PCOS. Now, if you do I use clomiphene much? I don't, not in ovulation induction, and I will come to letrozole later, and I'll explain to you why. Now, let's say you gave clomiphene, and then in 10 days you don't see any difference at all. So what do? Do you tell the patient to go home and come back on a higher dose, or let's change to letrozole? And patients are often paying for medication. So I'll say, why don't you utilize the same treatment and do something called as a stair-step protocol? So what does it mean? It means that you reassess on day 10, and if there's no response, you push the dose of clomiphene higher, and you give 100 milligram again for 5 days. and review it after 7 days. And what that study showed us, and there are a lot of studies that showed us that the number of follicles was better. It seemed to work in some number of cases. So where would I use it? I tend to use it mainly in where you started clomiphene and you don't want that cycle to go waste and you want an ovulation to occur, because if the woman doesn't ovulate, she's not going to get pregnant. So rather than wasting a cycle, I'll say, well, why don't you give this a try? So now, some of us rarely use clomiphene, and so we are now heading towards letrozole. And why do we use letrozole? And I'll explain. I'll give you the idea. So it's a non-steroidal. It blocks the conversion of androstenedione to estrogen, and has been traditionally used for breast cancer. And a letrozole dose of 2.5 to 5 milligram is almost free of side effects. So unlike the clomiphene, it does not block the receptors, and so it has its benefit. So if you have a look at clomiphene and if you have a look at letrozole, what is the basic baseline difference of FSH? So at the end, what do you want? You want the way the FSH pulses occur, and because FSH is going to stimulate your ovaries. Now, if you look at the natural cycle, clomiphene gives you a higher baseline FSH for a prolonged period. So have a look at here and it'll give you a higher baseline FSH continuously. And that's the reason why it recruits more follicles. Letrozole does something very different, and letrozole gives you a higher peak. So depends what you're looking at. If you're looking at getting a higher peak of FSH in the first few days, letrozole does better. Even if you look at ovulation induction, again, decide what you want. If you want a sustained FSH, clomiphene does better. If you want a faster peak of FSH that then drops as in nature, letrozole does better. And both seem to have a different action. So what we have to test is letrozole the first line of treatment and its safety factors. So I'll say, well, I'm not going to present all the studies on letrozole, and I'll say, yes, it is the first line of treatment. And it has been proved beyond doubt that in PCOS, letrozole should be used as a first line of treatment, and the ESHRE guidelines also confirm it. So what we'll go and do is we'll say, well, what works better? And this was based on a very good trial, again done by Richard Legros. And if you read his papers, they're very much papers that are looking at how general treatments tend to work. So again, these were PCO patients, and they gave clomiphene 50 milligram or letrozole 2.5 milligram, maximum dose 7.5, and clomiphene 150. And there was no trigger, and that's why it is important. And sexual intercourse was between 2 to 3 times a week. So if you look at the live birth rate, letrozole does better. Pregnancy loss, very similar. But have a look at ovulated, and almost 90% of women ovulate spontaneously on clomiphene, and only 76% ovulate spontaneously on clomiphene. So remember, each of these drugs will have a failure to ovulate, which means that the pituitary does not respond. So giving clomiphene and saying, go and try at home, you'll be seeing a quarter of patients who will not have an LH surge and who will not ovulate. And that's something which is important. So where is letrozole important? It gives you a better live birth rate, but it also gives you a better ovulatory rate. And that again is important. Both drugs cause significant hot flushes and mood swings, and congenital anomalies are statistically very similar. So that is in short about clomiphene and letrozole. And we say, well, that doesn't work. And what do you do next? The next step is gonadotrophins. Now, a lot of people will say, let's go towards IVF, and IVF poses more significant changes. So what is the conventional regime for gonadotrophins in PCOS? And this is the older regime. It will require a lot of courage to use this regime now. So what did they do? They used 75, and at that time it was HMG. So you use 75 of FSH or HMG for 5 days. And every 5 days, they increase the dose by doubling it. And what they found is that if you do this protocol, you have a phenomenally high pregnancy rates, but you have more multiple follicle development, you have multiple pregnancies, and surprisingly, in ovulation induction, you have ovarian hyperstimulation syndrome. So what is now accepted? Now, what is accepted is using is known as chronic, which means it goes on for a long period, low dose protocol. And this is something which has generally been accepted. You can start with a dose of 50 to 75 and keep that fixed for 14 days. So if you, after 14 days, you look at 70, you increase it if you're on 75 at 25 or 112.5, and you just keep on increasing it. And what they noticed is that the multiple pregnancy rate still continued, but the ovarian hyperstimulation rate went down. And single ovulation was 71%, and fecundity, chances of pregnancy per cycle, significantly higher. Now, somebody said, oh, why don't I lower the dose? And they lowered the dose to 50. And again, they saw that your ovulation rates were much better and the chances of pregnancy also significantly better. So what is the logic here is they require a small dose of FSH and you want to give them a chronic low dose. Why? Because you don't want 20 follicles to grow. And why? Where is it important? If you have an IVF unit, it doesn't matter. You can go in and collect the eggs. But majority of people in the audience do not have an IVF lab. Majority of people who practice fertility, and rightly so, are in the community in towns and villages where IVF practice is limited. And my general logic is, as a fertility specialist, I tend to say it is not wrong for everyone to treat fertility, mainly because you cannot push everyone to an IVF unit. You don't have the capacity and patients don't have the funds. And a lot of IVF specialists will hold me and say, hang on, that's wrong. The doctors do crazy things. No, we've all done MBBS and all of us generally will have a reasonable amount of common sense to treat patients. So as much as information that you can give, including gonadotropins, give it so that people can use these practices in the periphery so that you can genuinely treat people requiring IVF in those cases. Now, what if you decide? Now, what I'm trying to do is I'm trying to show you multiple ways of trying to moderate your dose. And I don't give, if you ever attend my teaching, I don't give specific protocols. Specific protocols are not for doctors. We've done years of teaching and training. You need to have a think. And this talk on gonadotropins will show you that you can increase the dose very minimally, shorten the period, do as you like, as long as you don't give 20 follicles growing. So here what they did is they said, let's give 50 international units for 7 days, increase by an increment of 25. Or you do 50 and you increase by increments of 50 and you cancel if there are more than 3 cycles. And what they looked at, ovulation rates were very good when you use 25, so less cancellations. And monofollicular growth was also very good. So again, even if you do a minor increment in clomiphene resistant, it seems to work. And again, proving that you require a very mild incremental dose of FSH if you want to make this work. Now, this was a brilliant study done, and this was done on the very small, lean Vietnamese women, very low BMI with clomiphene failure. And the reason why it's important is that in rural India, if you go towards, and much of our study showed us that it's fertility sterility. And the surprising thing was we saw a large number of women who were slim and who had PCOS, who did not fit into any of the Rotterdam criteria and whose metabolic changes with diet were very different. So in these cases, very similar to the Vietnamese probably, and 25 international units for 14 days, and then increase it. So if you see a very mild dose, and they saw ovulation rate in 97% of cases, ongoing clinical pregnancy rate of 35%, which is brilliant. So what it's telling us is that you have to decide on how, if you can't do IVF, at what stage, how we can titrate the dose. Do you want to shorten the duration? Go ahead, do it. It seems to work. And pregnancy rates are much better. remember one thing with the earlier you increase the dose, you'll have more multiple pregnancies. The later you increase the dose, you'll head towards monoovulation, and that's something which you'll have to realize. So let's say we go and say we have looked at ovulation induction, and we'll say, well, a third of patients will get pregnant on ovulation induction. So that's done, and another third will get pregnant on gonadotropins and, if need be, IUI. And then there'll be a portion of cases who will come towards IVF, or those who have the male factor, or block tubes will require IVF. And where there's a challenge lies, and the challenge lies mainly in its, I'll say, let's put it, those ovaries which are metabolically challenged are more likely to have a difficult stimulation and a poor outcome in IVF. So if you see somebody who has amenorrhea for long periods, very small follicles, you have to warn them and say, see, IVF is not the best tool, maybe the only tool, but your chance of getting to good quality embryos may be limited. So you'll see excessive ovarian response, low fertilization rates, high number of immature oocytes, reduced cleavage rates, low implantation, high miscarriage rates. So if you're going to do, step back, understand your PCOS. Will they stimulate? Yes, they often stimulate very well, but understand it. Look at your AMH, look at the FSH, look at the LH. Why? Because you will see some women with low LH in which they have PCOS and the hypothalamus has been switched. So any LH less than 1.5 should be a cause for concern. Ideally, what dose should you use? You use a dose of 150. And that seems to work. Now, I'll step back and probably I'll say I'm much older and I've seen a lot more. So I can say you should be able to predict which ovary is going to be difficult and which ovary is going to be easy. So, I come from a generation which looked at Clint Eastwood movies. So I used to call it the good, the bad, the ugly. And I put everything into good and bad. We differentiate people also, good person, bad person. So to make it easy, I'll say good PCOS and bad PCOS. Reason is it helps us to know where treatment works. And if you look at, I call it jokingly the gray triangle. And so have a look at how you define it. So one is you have a high AMH, which means higher the threshold. What is AMH? AMH is an inhibitory marker. So it inhibits follicles from being released. So higher the AMH, it acts as an inhibition. Higher the volume of the ovary is higher the threshold. And I'm talking of the FSH threshold. Smaller follicles, 2 to 3 millimeter, and you'll see PCOS, very small follicles, incredibly difficult to stimulate. Why? The FSH threshold is higher. Look at the thecal element. Larger theca, more difficult. Why? Because theca is the core of androgens, and the androgens as an inhibitory person. Larger the follicle, easier to stimulate, and less the theca, lower the stimulation. So, and again, look at your PCOS, understand it. So you'll have something like the good PCOS, very easy to stimulate. We stimulate with 150 brilliantly. And these are, I call it the good PCOS. Now you've got the bad PCOS, where you see small follicles, multiple. This was when we started IVF, and she got about 70 oocytes and 3 blastocysts at the end. She had a baby eventually, but it means you went through so much to get to just 3 or 4 blastocysts. So this is how the ovary looks. I call it the fat triangle, and you'll see AMH, I call it picomole, but use the division of 7. And AMH that is high and decent, larger polycystic ovaries that you can see on a scan, 4 to 5 millimeter, easier to stimulate. High AMH, large ovaries, small follicles, more difficult to stimulate, and we want. So in IVF, you'll see a good response with 150, good blastocyst, good number of M2 sites, less risk of ovarian hyperstimulation. PCOS with a high threshold, you won't see no response. If you start on 150, you see 2 or 3 follicles growing. They do better on a step down. You see a poor progression and you see immature oocytes. Now, often you'd ask is, how do you treat these cases? Now, do we have drugs to look at insulin resistance? The answer is yes. Which? PCOS, metformin, and myoinositol. Should you give it? I'll say you can keep on reading evidence, but you have only two drugs which are going to treat insulin resistance medically. If you want to treat insulin resistance surgically, it's ovarian drilling. Maybe at some point I'll put it online. I've got a large talk on ovarian drilling, when to drill, when not to drill, and at what hormone levels you drill and what is the evidence. But I'll say avoid doing that if you can, but you have to do it sometimes. So use metformin and use myoinositol, because those are the two supplements and drugs which will help to lower the insulin resistance. And there are some ovaries that are so difficult to stimulate. The AMH is high, androgens are high, small follicles, they give you immature eggs. They may not get to a blastocyst stage, and even with an analog trigger, will go into ovarian hyperstimulation. So do you use the agonist or antagonist? And I'll say we're not discussing the agonist here. You should not use the agonist because you will burn your fingers sometimes. The other problems you see with PCOS is premature luteinization and premature ovulation. And I'll probably tell you, which drug to use too. So what trigger do you use? So let's briefly look at the triggers and what does a trigger do? And if you want to understand a trigger, you have to believe that nature works on the level of LH activity. The luteal phase is LH activity driven. So in nature, what happens? In nature, the LH, if you see this 14, 14, and 20, that's a natural LH rise, which is 48 hours. So the LH activity is 48 hours. Analog trigger is only about 24 hours, and HCG lasts for 7 to 10 days. So again, understand what is the luteal phase. The luteal phase is LH dependent in the first 7 days after ovulation, and it is HCG dependent after the peak of progesterone, which means that if there is no pregnancy, the corpus luteum starts dying. So what helps the corpus luteum to survive in nature? It is natural HCG. LH is what supports in the first 7 days of ovulation. So if you extend the LH activity, and how do you extend it? By giving HCG in the early luteal phase, you will give rise to multiple corpus luteums, and they will push the ovary into ovarian hyperstimulation syndrome. So always the agonist, but what does the agonist do? It acts for 24 hours, so it disrupts the endometrium and it disrupts the corpus luteum, and you have a short luteal phase, and pregnancy rates will be lower. Adding estrogen, adding progesterone is a waste of time. The only drug that rescues the luteal phase is HCG. So why should you use the agonist? OHHS is almost prevented, not always, but almost prevented. Prevention is almost total. And you should use the antagonist because that's the only way you can use the analog trigger. So you say, hang on, and I don't want to freeze embryos. I want to give the analog trigger and I want to do a fresh transfer. Yes, you can do it. Peter Humedin showed that if you gave HCG, a small dose on the day of ovum pickup, not as a trigger, you enabled the endometrium to recover and pregnancy rates were much better. Problem is, do you see in his study, there was no ovarian hyperstimulation, but remember, they were not Northern European patients. Generally, you will see severe ovarian hyperstimulation too. See, the other problems you get with IVF are receptivity is increased, contractility is increased, high progesterone levels may lower implantation rate, and there's a controversy at what cutoff we should use, the risk of overstimulation, and finally, there is a success of cryopreservation. So what do? We'll say, well, use step-down protocol if needed, stimulate, Wait till the follicle size reaches 18 because LH acts better on follicles between 18 and 20, and smaller follicles don't respond well to LH. Freeze all embryos and then replace them in a frozen cycle, and you see a significant better chance of pregnancy. And this was one of the first studies which came. And in fact, in the UK, we did probably the largest studies on a freeze all on our NHS hospital. And that probably showed that a freezing was safer and gave much higher pregnancy rates. So finally, I'll say, which drug do you use? Which drug do I use? I use HMG, and I'll show you the reason why. So what is traditionally taught to us, and that was, I'll tell you, the history goes when Merck came into India. And I remember I was a trainee at Bombay Hospital then, and I attended a lecture where they said, in PCOS, they already have high LH, you should not give LH. And it was a phenomenal marketing plan. And I admire medical reps because, they're like the press, they are needed, but like the press, they can convince highly educated doctors and people that what they have learned over 20 years as doctors is nonsense. And what 2 years of medical research on drugs is the truth. And this is how, we gave Gonalef and all the other recombinant left, right, and center. And it's completely wrong. So what happens? Does HMG lower recruitment? Answer is yes. That's what you want, don't you? So when you give HMG, it increases LH levels, but transitory. For the first 5 days, it increases LH levels. So it knocks off small follicles which do not grow. And so the benefits of HMG is it gives you an initial rise of LH, fewer follicles are recruited, it may knock off small follicles, slightly better at lowering progesterone, and fewer small follicles grow, and this may in the end give you lower progesterone levels. So let's look at the other studies, and they looked at combining fresh and frozen cycles, and what they noticed is that the live birth rate with HMG with PCOS is better. It gave better results in a fresh cycle. So if you are thinking of fresh cycle ever, HMG will give you better results. Almost a significant change in live birth rates. Cost, in the UK, both cost very much the same, but in many areas, HMG costs less. If you look at the MERIT and the MEGASETS study, as soon as you used recombinant, your progesterone levels increase. Why? Because FSH, which is recombinant, is more biochemically more potent. It stimulates much more. It stimulates smaller follicles much more. So your risk of overstimulation also increases with recombinant. Again, we looked at the AMH, and they looked at, and this was a good study where they looked at high AMH and they looked at the long protocol, HMG and FSH, and the antagonist protocol, HMG and FSH. And what they noticed is, irrespective what protocol you used, your progesterone levels grow much higher if you're going to use recombinant FSH. So again, what it is telling you is it's a more potent drug. It recruits more follicles, and you will face the problem of getting more follicles and probably more progesterone. And if you look at pregnancy rates, very much similar or higher with HMG. So this was the one which was done very recently, where they looked at, they did an RCT, and they looked at which was better. So it's a non-inferiority trial. A young woman cycles between 21 and 45 days, high AMH. HMG and Gonalef used, starting dose 150, maximum dose 300. It's not costing, it's costing. 250 hcg given for a fresh transfer, and 4 milligram Lupride given, and a single blastose is done. So I'll cancel. I'll tell you the summary of this. HMG gave lower estradiol levels. So if you want this paper, I presented this on fertility courses. They're close to 350 videos there, and on Facebook there are about 500 videos, and you're free to subscribe and watch them whenever you want. And so it gave a lower progesterone, lesser number of oocytes, number of blastocysts were lower, but number of top quality blastocysts was similar. Aneuploidy rate was similar, and a higher ongoing pregnancy rate was present with HMG. Live birth rate with fresh transfer was better, and live birth rate even with frozen transfer was better. If you look at the ovarian hyperstimulation, HMG reduced the rate of ovarian hyperstimulation. So the important points from drugs, I'll say it has a lower pregnancy loss in fresh and frozen transfers. Differential pregnancy loss was observed in frozen. Fewer oocytes, but similar number of top quality oocytes, and significant differences were not observed in aneuploidy. In conclusion, the paper said you should think of using highly purified HMG. Again, the problem with HMG is you have to use HMG from a good provider, a good company, because HMG can be produced at a cheap rate from anyone. And finally, if you look at this paper published recently, they said if you give FSH, you get more oocyte, more M2 oocytes. The number of embryos very similar. Implantation rates better with HMG. Pregnancy rates better with HMG. And basically the same thing which is being said. So that's in short about PCOS. I've never covered the entire treatment of PCOS in one go, but that's it. So I'll take any questions if you have.
Any questions? Any question from audience? Thank you very much, sir, for a very nice and informative talk. You have covered all the treatment of PCOS, especially using HMG, which were a little bit doubtful about this. Thank you, sir.
Thank you very much.
Thank you, sir. Please accept e-trophy from Solapur OBGY Society.
Trophy, I want the WWF trophy. Yeah, thank you very much.
Sir, thank you.
Thank you.
Okay. Thank you, sir. Thank you very much.
Sir.
Do you want to add something, sir?
Yeah.
I request Dr. Basutkar ma'am, please felicitate our chairpersons. It's great privilege to give vote of thanks on behalf of my team. I am thankful to our esteemed faculties, Dr. Aditya Khut, Dr. Vaman sir, Dr. Anil Guddi for great lectures. Our enthusiastic moderator, Dr. Milind Shah and Dr. Vidya Tirankar, and our panelists, Dr. Smita Chakote, Dr. Vaman, Dr. Shashikant, Dr. Shraddha, Dr. Poonam and Dr. Aditya for wonderful inputs on all about PCOS. Thank you, our chairperson, Dr. Bharti ma'am, Dr. Sharmila, Dr. Sampath sir, and Dr. Sulba Zambre. Thank you, senior, my colleague, friends, for attending CME in large number. Thank you, Balaji Sarovar for best venue, Mr. Shedzare for audio visuals, Mr. Mohan for photography, and Mr. Ivare for helping us to make this CME a great achievement. Last but the most important, Acumentis and team as a pharma partner. I request everyone for a delicious lunch. Thank you.